All right, so we'll go ahead and get started. It's just a little bit after 8. Well, thanks everyone for taking some time out of their Sunday to join us. We really appreciate you spending a little bit of time with us. And I think we have some great talks for you this morning, which will hopefully make it interesting and interactive and a fun event. So we'll just go ahead and get started here. Okay, so as everyone knows, this is obviously we're the doctors from the Eye Care Center of Northern Colorado. And just give our little bit of introduction. Most everyone knows us well, but we're comprised of the Eye Care Center and then also our Advanced Vision Surgery Center. So our retina team is composed of Dr. Benedict, Dr. Tilton, myself, and Matthew Manry. And so a little bit of interesting couple of updates. So Dr. Benedict, sadly, is retiring at the end of this year. His full-time profession is going to change from excellent retina doctor to professional skier and mountain biker. And so he's going to be moving on to the next phase of his life at the end of December. And we are really going to miss him. And we've really obviously enjoyed practicing with him. And, you know, hopefully all of you, everybody will get a chance to say goodbye, and he won't disappear. We'll make sure we drag him back for some meetings and make sure we show him around. But in preparation for that, we have a new member of our retina team. His name is Carl Noble, and he's actually on the meeting with us today, and he'll be giving a presentation. And I'll let him introduce himself a little bit. Carl, do you want to tell everybody a little bit about yourself?
Yeah, sure. So nice to meet everyone. Really excited to be coming on board with the team. I'm at a fellowship here from Cincinnati, where I did 2 years of vitreoretinal surgery fellowship, and kind of cover the whole gambit of comprehensive surgical retina care, and happy to take any patients on. And if you have any, I'll put my contact information at the end of my presentation, but if you have any hot potatoes on your schedule for retina that you need to get off your plate, I'm happy to help out. And you can send me a text or an email anytime with any questions. But nice, hopefully get to meet all you guys in person here soon.
All right, great, thanks. Members of our glaucoma and cataract team, Dr. Rosting, Dr. Sheth, and Dr. Parikh. And then Dr. Myers, oculoplastics and cataract, Dr. Werner, cornea and cataract. And then our excellent primary and comprehensive eye care with Dr. Crone, Dr. Wolford, and Dr. Burton. And then Advanced Vision Surgery Center is our dedicated state-of-the-art surgery center dedicated exclusively to ocular surgery and lasers. And then, as you all know, we have a number of locations to serve you and your patients: Longmont, Boulder, Lafayette, and Greeley. Lots of different ways to get in touch with us via phone or our cell phones anytime. You guys can always call us if you have questions. And then also on the website, you can put referrals through online. So something really interesting, another exciting change this year has been that we've been trying to get this accomplished for a number of years, but we have finally started our Advanced Vision Research Institute, which is now allowing us to do clinical trials for patients. And this is something we are really excited about. Not only, offer state-of-the-art care, but also those sort of future care for some of those unmet needs. And so we have 3 clinical trials that are going on right now, and we're always interested in would love your help in recruiting patients for these trials. So I'm going to tell you a little bit about each of the trials we have going on, and then we'll move on to Dr. Tilton's presentation, because this is really exciting for us to be able to do clinical research. So the first trial that we have going on right now is called the Unity trial. And it is a trial looking at a new treatment for diabetic macular edema. So as everybody knows, there's a number of patients who, despite monthly injections of an anti-VEGF or steroids or other laser, or just basically the best care we can give, these patients remain with fluid in their retina. And so this is a trial looking at a new medication to try to address that unmet need of diabetic patients who, despite the best state-of-the-art care, still have fluid. And essentially what it's looking at is it's looking at a medication which is going to try to essentially prune some of the diseased cells from the retina, which will then, the hope is, allow the healthy cells to sort of regrow and reestablish the natural balance in the retina. And so this is an exciting new drug. And so basically what we're looking for is we're looking for patients, oops, sorry, that's the next trial. So we're essentially looking for patients who still have center-involved diabetic macular edema, still have a thickness of over 350 and between 2040 and 2400, and essentially are getting maximal therapy with monthly anti-VEGF. So this is an exciting trial that we're recruiting for right now. Second trial is called the SHORE trial, and this is a phase 3 trial looking at a new medicine for wet AMD. And so essentially, as everybody knows, we have a number of treatments for wet AMD right now. Two examples are Eylea and Lucentis. With Lucentis acting on the VEGF-A receptor, blocking VEGF-A, and then Eylea blocking both VEGF-A and VEGF-B. But there are two other isoforms of VEGF called VEGF-C and VEGF-D, which currently are not addressed with the current medication right now, which can promote angiogenesis. And what this medicine is basically, it's a second supplement medication, looks at blocking the VEGF isoform 3, C and D, and see if that can both improve the response and improve durability. And so this is a really important trial for actually that we would really need everybody's help recruiting for, because this trial we're looking for treatment naive patients. So essentially they have to have had never have had treatment in that study eye. And so we're looking for people with a new choroidal neovascular membrane involving the fovea, a visual acuity score between 2063 and 2317, and basically at least 50 years of age or greater. And the hope is that this will actually allow these patients to have both a better outcome than we can currently give, and actually maybe in the end up needing less injections overall with this new treatment. The last trial is a completely unmet need in ophthalmology. This is looking at a medication for actually geographic atrophy, which we currently have nothing for. And so this is a phase 2 trial, and it's actually an oral medication. And essentially what this medication does is block part of the alternative complement pathway. It blocks complement factor D, which, you know, in the multiple bubbles, it is the complement pathway that nobody actually really can remember. It's one of the earlier parts in the complement cascade, and blocking that will, in theory, decrease inflammation. And so we're looking for patients who are over age 70, geographic atrophy in at least one eye. And this is something that'll need to be determined by the reading center, but essentially this is the size of the geographic atrophy. But this is really exciting because it's an oral medication and it's something with completely unmet need in ophthalmology. So we are very excited about these new research studies. And so we'll keep everybody up to date, and hopefully you'll keep this in mind for your patients. And if you have any patients you think might benefit from entering any of these research trials, just let us know. And after the meeting, we'll send out sort of a more detailed list of what the trials encompass and some of the inclusion criteria, because obviously it's really hard to remember just from slides. And then one other piece of, I guess, two housekeeping. Just wanted to let everybody know to help us put on this presentation, we got grant support from Glaukos. And they basically they make the iStent inject, one of the glaucoma procedures we do. And they also are do corneal cross-linking. And so we just wanted to thank them for their support and helping us bring these meetings to you. We wouldn't be able to do it without the support from some of our industry partners. So with that, I'm going to turn it over to Dr. Tilton. Looks like there might be two questions. question. Okay, all right, no questions. All right, great. So we're going to turn it over to Dr. Tilton, and Dr. Tilton's going to start his presentation. At the end of everybody's presentation, there'll be a QR code on the screen, and that's going to be the best way for everybody to claim their continuing education is by scanning that QR code. If anybody has any trouble with that or difficulty, just let Priscilla know, and we will get those QR codes to you again, or we can do it via paper or any other way. And without further ado, Dr. Tilton.
Make sure I was unmuted. Good morning, everyone. Thanks, Justin, for introducing everybody and introducing our clinical trials, which is certainly very exciting. My talk this morning is, when thinking of this talk, I just wanted to spend a little bit more time on 3 or 4 common conditions that come into my office all the time, my retina practice, but to spend a little bit more time because some of these conditions have little nuances or questions that I ponder. So just to get started, my first case, and I have survey questions you can all respond to. We'll see how that works. But this is a 28-year-old who presents with vision loss, and just to make it a little bit more participation here, possible causes of the condition that you see on the photograph could be, you can see them listed there: factor V Leiden, use of oral contraception, exercise at 12,000 feet, or all of the above.
Oh, sorry, technicals. So Carl, so actually, even though Elijah Tilton questions would make sense, actually don't use that poll. Do the number 1, 2, 3, and 4. My fault there. Sorry.
I believe that's how you have it set up here.
Okay, we'll go ahead and launch that one and we'll see how it works.
So I guess it's on here. It's just the first question. Just click click one of the answers. All right, so I'll continue with the talk then. Can people still click on it afterwards, or is it?
Yeah, I'll leave the polling open until you're done with the with the 1, 2, 3, 4, and then I can close the polling after that and show the results or all of that.
Well, it comes up at different points, so
I'll just leave it open until we're done with your questions, if that's okay.
Well, it's in my. I guess I can move it. Okay, there we go. All right.
Is that better?
Yeah, I just moved it off to the side.
Okay.
Great. So a little more background on this first case. He's a healthy 28-year-old, has a history of childhood asthma and a cyst that was found out to be benign from one kidney. That was removed about 5 years ago. He says he's healthy, never had any issues with his health other than the 2 things that I listed, and he exercises regularly. 3 days ago, lost his sight, like it was looking through frosted glass, and then felt to him like it was coming and going for a couple of days, and then came back to almost normal after that. He reports that after I questioned him, what were you doing on the day that you lost vision? He said that, well, he went on his longest bike ride that he'd ever been on, which was, I can't recall, it's something around 100 miles, and included going over Vail Pass. And he said on one of the hottest days, when we had some of our hot days in the early summer. So he, after seeing this presentation, I ordered a complete coagulation workup, which came back all normal. He initially had presented to the emergency department, so he got a brain and orbits MRI, which was normal. His blood pressure in the office was normal with a normal heart rate. And on the left, you can see his RetNet presentation. A month later, it is back to normal. His initially had dilated veins, a few intraretinal hemorrhages, and some vascular tortuosity, and it's returned to normal after 1 month. The next case is similar to the first. It's a 35-year-old man with no medical problems. He reports that he's a very active person with no medical problems. He interestingly has a family history of a factor V Leiden in a mother and sister, but believes he was tested when they were first diagnosed and that he was negative. He lost vision suddenly in his left eye while rock climbing at around 12,500 feet on Long's Peak. And he also said this was probably his hardest climb he'd ever done. And this was his eye at presentation. Again, some venous congestion, intraretinal hemorrhages. His workup also was normal. His factor V Leiden checked again was negative. His blood pressure was normal. And after 6 weeks, you can see his retina returned entirely to normal as well. So both these young men had a central retinal vein occlusion in one eye. Central retinal vein occlusion is the second most common vascular disease after diabetic retinopathy. And it's caused by, most commonly, a thrombus that occurs at a junction between the artery and vein, where the thickened artery compresses the adjacent venous wall. Much less common is a clot due to a hypercoagulable state or a compressive structural problem, such as optic nerve head drusen. The majority are non-ischemic, or 2/3 are non-ischemic, and about 1/3 are ischemic, as defined by having a certain amount of area that show non-perfusion on fluoresceint angiogram. About 0.5 to 1% of the population will have a retinal vein occlusion in their lifetime. As I said, the majority, or 90%, are older than 50. In patients that are younger than 50, like these two patients, you have to think of causes that can include medications, hormone treatments, so oral contraceptives and hormone replacement treatments are a definite risk factor. There can be structural abnormalities, hypercoagulable states, and blood dyscrasias like polycythemia, dysproteinemias, vasculitis, including sarcoidosis, lupus, and various infections, and hyperviscosity states. This is my basic, or actually not basic, but my complete lab workup for central retinal vein occlusion. Sometimes I'll do some of these, sometimes I'll do all of them, and sometimes I will do some basic things and then send the patient to a hematologist. And of the causes of thrombophilia, the relative risk of developing venous thrombosis anywhere, you can see protein C deficiency and protein S deficiency have a very high risk. Hyperhomocystinemia has a elevated risk, but a little bit lower than some of the others. But if you look at retinal vein occlusion specifically, hyperhomocystinemia is the highest risk or the highest factor found in doing a workup. So both these cases are young, athletic adults with no risk factors for no particular risk factors or thrombophilia by their lab workup. I found two institution reviews to look at. One of them was from Duke, and they found 36 patients under 50, 10 of which had normal lab workup. And they found that of those 10 that had a normal or incomplete lab workup, that they had traditional risk factors for vein occlusion, including hypertension, diabetes, hyperlipidemia, smoking, glaucoma, the kind of things that typically would cause a vein occlusion in an older adult. Two were that had a negative workup were ultra distance runners, and in a second institution in Sweden, they found 3 of the 22 had no risk factors or lab abnormalities, and 4 of the 22 had dehydration as a history before developing central retinal vein occlusion. So in these two cases, it's possible that they are related to exercise, and there's a condition that's been termed marathon runner's retinopathy. And this is where people get a central retinal vein occlusion occurring during endurance events without other risk factors. And we don't know the cause, but dehydration and platelet activation during exercise may be possible causes. Both these two young men were exercising at relative altitude, and so it brings up the thought of the influence of high altitude retinopathy, which is not specifically a cause of central retinal vein occlusion. It's its own entity, but it's interesting to think about whether this is a factor in these two people. Usually we think of high altitude retinopathy occurring at altitudes higher than what we have in Colorado. And it's a where people get intraretinal hemorrhages, dilated retinal vessels, sometimes with vitreous hemorrhage and papilledema. The high altitude retinopathy occurs, as you can see, there's been a number of studies. All are relatively small because it's difficult to do all our testings at higher altitudes. But it can range from 1 to 2% in lower altitudes, up to 90% in higher altitudes, 25,000 to 29,000 feet. With high altitude retinopathy, there is vascular dilation, which can be induced by studying patients in a hyperbaric chamber, relative low oxygen levels, and also by studying people at altitude, finding increase in vascular dilation, both of the arteries and the veins. And the dilation can persist for weeks after exposure to altitude or hypoxia. But specific risk factors for greater development of high altitude retinopathy are higher ascent, greater rate of ascent, a longer duration at altitude, the activity that you're doing at altitude, possibly the use of non-steroidals, and then individual susceptibility, and certainly related to the measurement of oxygen saturation by pulse oximetry, and there's a relationship to higher hematocrit, higher baseline intraocular pressure. And interestingly, the younger people who are younger and better physically trained have higher incidence of high altitude retinopathy. It's possible because they are, and linking back to greater strenuous activity while at altitude. Just some of the studies that were done using different techniques to measure blood flow and find that retinal blood velocity increased up to 18,000 feet, and then showing some decrease, and choroidal blood velocity increased and remained elevated, and that vascular dilation noted to increase with ascent. Apart from the vascular dilation and velocity, there is some hyperviscosity, which is secondary to polycythemia at altitude, and that increases coagulability and hyperviscosity. Also at altitude, there's other factors: coughing, straining, Valsalva. The dry air causes an almost universal cough. It can be strong enough to cause rib fractures. There's also some studies looking at the particular vascular dysregulation, where you get engorgement of the blood vessels, increased blood flow, but also at the same time some localized release of vasoconstricting factors, and this dysregulation can lead to hemorrhages in the retina. Then along with high altitude retinopathy, there's high altitude cerebral edema. And with that, people get papilledema. Papilledema causes increased venous pressure, and that also leads to retinal hemorrhages. So if you put all these things together, you can see multiple reasons why we'd see retinal hemorrhages in climbers or people at altitude. The hemorrhages, interestingly, most commonly occur after descent. So if we examine people at altitude, here's one example of a person at baseline, and then up to 20,000 feet here, still looking without hemorrhages, but some vascular dilation. But the hemorrhages only occurred after going back to 14,000 feet. And then this last was 4.5 months later, when they're back to baseline. If you look real closely, there's a little residual abnormality where one of the hemorrhages was. And that's common, that the hemorrhages usually resolve without permanent scotoma, although it is possible. When high altitude high altitude retinopathy can be a warning sign of possibly developing high altitude cerebral edema, and as many as, and according to this report, 50% of climbers with high altitude retinopathy developed high altitude cerebral edema. So finding or detecting high altitude retinopathy or hemorrhages during a climb should or could possibly indicate that a person has to get down to lower altitude before they start to develop cerebral edema. So back to our case here, in this particular condition, without knowing other background, 28-year-old with vision loss in this picture could be due to factor V Leiden, could be due to oral contraception, and certainly could be due to just exercise at 12,000 feet alone, or ultra endurance exercise. So I find these cases interesting, and I'd be curious to know if we did a review of all of our cases of young or people younger than age 50 who develop central retinal vein occlusion, and with a normal, otherwise normal coagulation workup, would it be higher than the studies done in North Carolina and sea level in Sweden? and also because we have such a high population of ultra endurance athletes in our area. This is not that uncommon a picture to see. So interesting case number one. Going on to case number two, here's a 80-year-old woman with this incidental finding, and we can answer our survey now.
Looks like I figured it out, Dr. Tilton. So
okay.
Our polling looks a little better now. Sorry about that from before.
It's okay. So, so switching gears, this condition that you see on the photograph is Coates disease, macular telangiectasia, macroaneurysm, or microaneurysm.
I'll give it another couple seconds here.
Okay.
All right.
So I like it. I like people are participating. Makes me feel good that I'm not just sitting alone speaking to my computer. So, sorry, this case is a retinal artery macroaneurysm. It's a macroaneurysm is a dilation of one of the retinal arterioles, usually within the first three branches of the arteriolar tree. It's 3:1 female to male ratio, and it's typically in people older than age 60 with a high relationship to hypertension and other atherosclerotic risk factors. And it's secondary to a weakness in the blood vessel wall, possibly due to focal ischemia, perhaps due to chronic hypertension, or inherent structural defects. The natural history of retinal macroaneurysms in 41 patients with an average visual acuity of 2200 or worse. And these are patients who developed a macular hemorrhage secondary to the aneurysm. After a year and a half, about 37% had vision improved at 20/40 or better. 29% had some vision improvement, but still at 20/50 to 2100, and a third remained at 2200 or worse. And poorer vision is associated with pigmentary changes after the absorption of blood. Treatment possibilities, we have laser, can use laser to reduce leakage. And if you've got an aneurysm that's leaking and causing exudate and fluid to build up in the retina, the risk of doing laser is that the laser itself can induce a distal occlusion, can induce hemorrhage, and potentially breaks in Bruch's membrane, inducing a secondary choroidal neovascular membrane. Another way of treating these, if there is leakage, is to treat them with intravitreal injections of anti-VEGF, like we do for many other retinal conditions. And this can reduce the leakage, although it's not curing the condition, it can be used to reduce some of the secondary edema. If there's significant vitreous hemorrhage, vitrectomy can be performed along with potentially pneumatic displacement of the hemorrhage and possible subretinal TPA. So this particular case, back to our photograph, this here is the macroaneurysm. On a red free, you can see it a little bit more clearly. It shows up right there. And then on fluorescein angiogram, it lights up, but it's not leaking. There's no edema associated with it. So at this point, when I saw this, we talked about potential treatment with laser, although I did not recommend it, as I was afraid that laser could potentially lasering right here could cause an occlusion to the distal blood flow, could cause a localized scotoma, or could induce a hemorrhage on its own. So felt that in her case, the best thing to do was observe and hope that it would remain without problem. Unfortunately, a year later, she came back and she had a localized artery occlusion, ischemia right around the macroaneurysm. There's no edema or hemorrhage associated with this, and you can see on OCT, it's just this intracellular swelling that I call opacification of the retina. So we, at this point, continued to observe. Again, there was no edema, and it was just ischemia at this area. But 2 years later, she comes back. This time she's developed a subretinal, intraretinal, and vitreous hemorrhage. And on her OCT, you can see she has some subretinal hemorrhage showing up here. It's pushing the retina up. And then a little bit of sub-internal limiting membrane hemorrhage. So this white here is a little bit of hemorrhage under the internal limiting membrane. At this point, vision had dropped to count fingers. And I discussed treating her with vitrectomy and subretinal TPA and pneumatic displacement. She decided she wasn't interested in surgery at that time. And so we ended up doing focal laser just to the macroaneurysm to hopefully reduce further hemorrhage and exudation. About 5 months after the hemorrhage, this is what her OCT looked like. She developed a significant epiretinal membrane, some subretinal fluid. Her vision remained at count fingers. And at that point, she decided she did want surgery. So I removed her epiretinal membrane. The subretinal blood has been there for 5 months. There's no point in trying to displace it or put in TPA. The clot is organized and scarred. But you can see after surgery, her apart from the area that has the subretinal hemorrhage, the rest of her macula is laying flatter. It looks better. Her vision still remained at count fingers, but her scotoma was perhaps a little bit improved. Unfortunately, she died a few months after this. The next case is also a macroaneurysm. 85-year-old woman. Only medicine is carvedilol for hypertension. She has a history of a heart attack. She saw a small spot on a Monday, saw an ophthalmologist who diagnosed with a small bleed, but her vision was normal at that point, other than that small spot. Over the weekend, she said she went blind and presented to me with count fingers vision in her left eye. And this is another patient, macroaneurysm in a similar location. And this patient has subretinal, intraretinal, and vitreous hemorrhage here. This is actually hemorrhage under the internal limiting membrane that's layering there. So this patient decided that she did want surgery to help clear the blood. So I did a vitrectomy with injection of subretinal TPA and a gas bubble to pneumatically displace the hemorrhage. And here you can see on our fluorescein angiogram the leaking macroaneurysm. Unfortunately, the video recording came out in black and white. Not sure why. It was done at the hospital, and but you can see this surgical video right here is a small gauge needle with a kind of a plastic tip. You can see that metal shaft, and then the needle shadow you can actually see because the needle itself is very hard to make out. The light source is coming from over here, and just playing the video, you can see the shadow coming together at this point. And then you'll see a flush of the injection of the subretinal TPA. I'll just show it one more time so people can see that TPA diffusing underneath the retina. So after that, I fill the eye with a gas bubble and ask the patient to position leaning forward, not totally face down, for a few days. And this is 1 week after surgery. You can see the edge of the gas bubble at the upper part of the eye. It's gotten small enough that it's revealing the macula, and you can see there's still a thinner subretinal hemorrhage. Some of the subretinal blood has been displaced inferior, and her vision at this point is improved from count fingers to 2100, or sorry, 2150. At 2 months postoperatively, she actually had a new subretinal hemorrhage that happened at some point in the postoperative period of time, but it wasn't large enough to cause extension into the fovea. So at 2 months post-op, she still has some subretinal hemorrhage, but the foveal area is clear and her vision is improved to 20/40. The case 2C is a 77-year-old man presented with a dark spot in his vision. He has a past history of hypertension, cholesterol. He's got a macroaneurysm in the inferior part of the macula with some subretinal fluid extending up into the foveal area, explaining his drop in vision. So this patient would not be one that I would want to treat with subretinal TPA, as his hemorrhage is smaller and sparing the fovea. I did, however, treat him with focal laser to that area, the macroaneurysm. Of course, he came back a month later with worse hemorrhage, this time involving the macula area. But interestingly, his hemorrhage was not subretinal, it was sub-internal limiting membrane. You can see on the OCT, the back part of his hyaloid. So his hemorrhage is trapped not by his hyaloid, but by his internal limiting membrane. And with him, I did vitrectomy, and all I have to do is just grab that internal limiting membrane and peel it away, release that hemorrhage, and no gas, no subretinal TPA. And here he is after surgery. His OCT looks good, his vision is improved back to 20/25. And actually, Amy will know this patient is, at the time, his vision was good in both eyes, but now his right eye has a neurotrophic ulcer and struggles with, I think, about 2100 vision. So it's good that he's been able to preserve his vision in that left eye after a few years. Another patient with a macroaneurysm. This patient had an aneurysm outside of the macula area. And so I just included this one because here's a case where just laser alone worked well. Treated him here at presentation with laser. This is a couple of months later, the blood's starting to absorb. And then a year later, the blood is all gone with a little laser scar. A few years after that, he did have a new small hemorrhage around his macroaneurysm, but he's continued, he never had any serious complications due to that. So on this case, this is a retinal macroaneurysm. And then go on to our next case, this is a patient that I know well. This happens to be my mother. So 10 years ago, when she was 61, she had this OCT. And the question is, over time, this condition that you can see on the OCT will cause the affected eye to have worse cataract, macular degeneration, glaucoma, or dry eye.
We'll give it a few more seconds here, Dr. Tilton.
Okay, great. So this case, as I said, this is my mother. So she has an epiretinal membrane right here. It's a mild membrane. It's sparing the fovea, well, mostly sparing. She does have a little bit of a membrane over the foveal area, but very little distortion over the fovea. Her vision is good. She asked me hundreds of times what she should do for this, and I told her hundreds of times not to do anything for it because this was mild and her vision was good, and I didn't want to take responsibility for anything, having told my mother to do anything when her vision was good, and I had this little small epiretinal membrane. Here is her right eye, so not the eye I was just showing you. Her right eye, on the right is her photo from 10 years ago. She has a posterior polar cataract, which is that shadow there, but her macula looks normal, OCT looks normal. 10 years later, on her OCT, she has some subtle RPE changes in the temporal macula. Her cataract has gotten a little bit worse. Here's the left eye, the eye that I showed you on the right 10 years ago when she had that little bit of epiretinal membrane. You can see it on the photograph. It's just above the macula area, or in the superior macula area. 10 years later, her cataract is definitely worse. But what's interesting is you can see all these spots here. She's developed pretty extensive drusen. And the drusen are localized only to the area with the epiretinal membrane. So again, going back to her, this is the OCT done recently, where in the area with the epiretinal membrane, she's developed significant macular drusen. In the areas that do not have a significant epiretinal membrane, her macula looks normal. So this is an interesting example of the influence of surface pathology affecting the deeper macula. There's a strong association between vitreomacular traction and macular degeneration. Oftentimes, the location of choroidal neovascular membrane corresponds to any area with vitreomacular traction. And this can be, if you have one eye with traction, that's most likely the eye that will develop the choroidal neovascular membrane. This was analysis looking at a control group with no macular degeneration, patients with non-exudative macular degeneration, patients with exudative macular degeneration, and the association between vitreomacular traction and choroidal neovascular membrane. Prior to our extensive use of intravitreal injections, vitrectomy was studied as a way of treating patients with choroidal neovascular membrane with some good results, really, given the poor natural history before we had intravitreal injections, that peeling and releasing traction actually improves the choroidal neovascular membrane and leakage. Possible causes of why the traction would lead to choroidal neovascular membrane. There's thought that low-grade inflammation from that chronic traction occurs. Perhaps you're increasing increasing inflammation and exposure to free radicals and cytokines there in that area. There's a possible, we know from diabetes that there's decrease in oxygen perfusion into areas that have an epiretinal membrane or traction. Here's just some more pretty pictures of traction localized over choroidal neovascular membrane. And an example from, not my case, but one example from a published study looking at doing vitrectomy, releasing traction, and improvement in this pigment epithelial detachment, choroidal neovascular membrane flattening out after surgery. This is one of my cases, one of my patients who initially presented with localized traction right over his area where he developed a choroidal neovascular membrane with leakage. I treated him with, or have been treating him with monthly intravitreal injections, and his subretinal fluid has improved. He now has just a small amount here. His traction remains, and I do want to now treat him with vitrectomy to release this traction, as I think it might help his ongoing care and may reduce his frequency of intravitreal injections. Epiretinal membrane is similar to vitreomacular traction. The incidence is fairly high. We see a lot of people with epiretinal membrane. Some of them are asymptomatic. Risk factors, anything that disturbs the eye can potentially lead to greater development of epiretinal membrane. And vitrectomy works well to improve vision, but we don't often talk about doing vitrectomy for ERM on patients who are asymptomatic. And this is just a video of peeling the epiretinal membrane, which, yeah, just prior to this talk, it wasn't playing, so I think it's just not going to play. So this case is circling back to our question. In this case, the localized epiretinal membrane caused an increase in macular degeneration, and I see this very often where patients who have an epiretinal membrane in one eye almost always have worse macular degeneration in that particular eye. It's generally not, or not always unilateral, where we just see the macular degeneration only affecting the eye, usually some sign of it affecting the opposite eye as well. But the degree of developing both atrophy and potential choroidal neovascular membrane is greater in the eyes that have epiretinal membrane and have so in my mother's case, I told her for greater than 10 years that she shouldn't do surgery for this, and I don't know if I totally regret that decision. I still think it was probably the right thing to tell her to do. But now that she's developed the macular degeneration changes, the drusen changes, I did actually peel her membrane at the same time as doing her cataract surgery. So changing onto my case number 4, this is an interesting phenomenon that we see sometimes, and we put up our survey here. This is just based on the photograph. We've got what you can see on the photograph, these white lines throughout the macula area. And possible cause of this condition are vasculitis, vascular occlusion, a nematode or worm, epiretinal membrane, or exercise at 12,000 feet.
All right, I'm going to end the poll here.
Great. Oh, I love it. Good. So this particular case is another case of an epiretinal membrane. Here you can see an en face OCT with this membrane here and contraction and striae of the underlying macula. The OCT cross section, again, you see that membrane and significant stretching and dragging of the macula towards the center. These are two of the cross lines and two of the vertical lines, again, showing that membrane. And then this is after I did surgery on the patient, I released or peeled their epiretinal membrane. This is after surgery. You can see they still have macular thickening. So their thickening hasn't improved yet, although their vision did significantly improve, and their distortion improved. And here's his fundus autofluorescence image before surgery and after. Before surgery, you can notice the blood vessels, the tortuosity, they're all being dragged towards the center. And with that, the dark lines are his retinal vessels that are being dragged, again, towards the fovea. And the white lines are these printings, and this is where the retinal vessels used to be. And it's a way of identifying the previous location of the retinal vessels. And after doing surgery, the retinal vessels are then now overlying their previous printings, and so hiding that area of increased fundus autofluorescence. So this phenomena of retinal vessel printings, it can be seen in epiretinal membrane. It can be seen after retinal detachment. In retinal detachment, with the retina is displaced by the detachment, and then after it lays back, and if it lays back in a different location, you can see where the retinal vessels used to be on fundus autofluorescence. It can persist for years, so it doesn't fade or go away very quickly after, perhaps like after a retinal detachment. The vessels can return to the original location after the ERM is released, just like I showed in my case. And studies have, or at least this one study, looked at eyes with retinal vessel printings from an epiretinal membrane have worse metamorphopsia at the same level of visual acuity and macular thickness. So if you look at the patient's vision and their OCT thickness, if you see retinal vessel printings, they more likely are much more symptomatic. Here's another case from a published article again. This one here showing the printings here after and oh, actually, I'm sorry. So this first case was a retinal detachment with the printings there. The bottom case is with an epiretinal membrane before, with these printings here, and after the vessel's coming back closer to its original location, and the printing is fading over time. So on my last case, this is just an interesting case with something that people may not have noticed before, but if you look now, you may see this in some patients with epiretinal membrane. And so these white lines are cases of retinal vessel printing from displacement of the retinal vessels, in this case from an epiretinal membrane. So that's my last case. I hope you enjoyed reviewing some of the stuff that I look at often, as much as I do. If you're curious to know why I picked these particular cases, I guess the first case was because I like extreme endurance events, often at high altitude. So I wonder about my own particular risk for developing a central retinal vein occlusion or other hemorrhages, and also just because we see it so often in our population of mostly or many very, very healthy people in Boulder. The second case, macroaneurysm. My father actually developed a macroaneurysm, and so made me certainly bring that top of mind. And then the case of the epiretinal membrane was my mother. So keeping it all in the family here in my talk. The last case, no relationship, just an interesting case.
Thanks, Dr. Tilton. And next up, we're going to have Amy Werner giving us a talk on ocular surface squamous neoplasia. So take it away, Dr. Werner.
Can everybody see that okay?
Yes.
Okay, awesome. So I think that I have met most everybody, but my name is Amy Werner. I am the cornea refractive cataract surgeon here at the Eye Care Center of Northern Colorado. So this talk was interesting to put together. It's kind of like one of those field of dreams situations where I started putting this talk together about 3 months ago, and since then I've had probably about 3 of these patients come in that I biopsied that have come back positive. So I like to start presentations with a patient case. So this was this particular visit was before I joined the practice, but it was a 39-year-old Caucasian male with very fair skin and red hair who came in with a lesion on the right eye that he had reported had been increasing for about a year. He had a history of many non-melanomatous squamous cell cancers on his face and skin. He had had radiation in the not too distant future on his nose after he had Mohs resection. He did not report any immunocompromise, but he did have a long history of smoking. When he came in, his vision was 20/50, and after a few weeks of mitomycin C drops 4 times a day, 1 week on, 1 week off, the lesion improved and he was able to see 20/20. At this time, he opted against a biopsy and surgical resection because he unfortunately did not have any insurance coverage. He was to start insurance with Kaiser, so he was not exactly lost to follow-up, but he was, the thought was that he was transferred to Kaiser for further follow-up. And then on further history, it sounds like he may have had a red eye on this right side as far as back as 2013 when he was living in Florida and he had some intermittent irritation. So here are some pictures from his initial presentation in August of 2018. So you can see he has some thickening here on the temporal conjunctiva and some leukoplakic white areas in the inferior limbus and a lot of corneoneovascularization. So actually quite surprised based on this photo that he was able to see 20/50 even. So I came to meet him in April of 2019. So less than a year later, he came back and he was so photophobic. He was count fingers. I could barely open up his eye to do a good exam. He never went to see ophthalmology at Kaiser. He had had this massive progression of this ocular surface tumor. He had this exophytic mass here in the lower picture coming from the inferior fornix, and further neovascularization of the cornea there. So he had thankfully recently stopped smoking, but the sight-threatening condition was explained to the patient, and potentially the life-threatening situation was explained to him. He was, clearly living in at least a little bit of a state of denial. So talked to this patient about how serious this condition was and started him on a different topical drop called interferon alpha 2 beta, which I'll talk more about later, but is unfortunately not going to be available here in the US any longer, but started him on this 4 times a day, and discussed further steps that he would need to take, like an orbital MRI to look for tumor extension, possible tumor debulking, and lymph node biopsy. And this is a picture of his anterior segment OCT, and you can see that this lesion is localized to the epithelium with a lot of epithelial thickening there. So a few other things I'm going to talk about: pinguecula, pterygium ptatus, ocular surface squamous neoplasia, and then a little bit about primary acquired melanosis. So first up is pinguecula. So these occur at 3 and 9 o'clock, and they occur in the interpalpebral region, nasal more than the temporal quadrant. There are a lot of theories as to why the damage occurs in this area, and more commonly on the nasal side as opposed to the temporal side. One theory is that the light is reflected off the nasal bridge. And then another theory is, here you can see the photo down below, that the cornea acts as almost like a lens to focus that temporal light on the limbus there nasally. So it consists of actinic damage, very similar to other skin damage from ultraviolet radiation. And you can get some disc keratosis and thickening of the skin above pinguecula. And I have biopsied some of these before, just to be sure that they weren't ocular surface squamous neoplasia. And sometimes they're benign, but sometimes also surprised. And interestingly, almost all of us will have this by the time we're in our 80s, just from actinic damage from the sun. Treatment is mostly non-surgical, topical, non-steroidal anti-inflammatory drops, preservative-free artificial tears, and steroids. And in a few occasions where people have been very symptomatic and unable to tolerate contact lenses, maybe once or twice I've taken these off. This is a patient I saw last week. So, it's a risk-benefit discussion, but I never use minomycin when I take off these small pingueculae. This is a patient who had, based on the surgeon history, had a lot of minomycin C use. As a surgeon out in California, and the pinguecula was removed for cosmetic reasons. So she has some thinning and melting of the sclera there nasally, causing her to be very dry, have lots of foreign body sensation, have lots of redness. She's dependent on steroid drops. So she actually had, the other eye had a conjunctival autograft with Dr. Richheimer, and she's doing really well with that eye. So we're going to take her back and help her out with this left eye here in a few months. So pterygium, the word comes from the ancient Greek word pterygios, which means wing. These are highly vascular, and they may originate from pingueculum. It is controversial, however. Once they cross the limbus, they're no longer a pinguecula, they're a pterygium. So if they happen most commonly next to the equator, and not using sunglasses puts people at about a 5 times greater risk of developing these. Men are more likely to get them than women. Again, more common in the nasal interpalpebral fissure, more common in folks that work outdoors, and they tend to occur the most in those that are in the 20 to 40 age group. So UV light's definitely a factor. And then also the thought is that chronic microtrauma can also contribute. So things like dirt, sand, and wind. So Colorado is the perfect environment to develop these. So the pterygium destroys Bowman's layer, that layer underneath the epithelium in the cornea, and it does this by producing matrix metalloproteinases. And there have been some reports of ocular surface squamous neoplasia that have arisen from the site of a pre-existing pterygium. So when I take these off, I always send them for pathology to look for any signs of atypia. And this bottom photo here is a patient. Sometimes these surgeries can feel a little, thankless, because although the rate of recurrence is very low, it's only about 2 to 5%. Their ocular surface is not normal. So a lot of times people will still have some redness and irritation and foreign body sensation. But this was my favorite pterygium that I removed. You can see here it's temporal, which is a little atypical. And he had this growth prior to a chemical injury a few years ago. And the chemical injury really sped up the progression of the pterygium. It's crossing the visual axis. He could only count fingers, and he has symblepharon formation here. So we removed this and did a little bit of fornix reconstruction with a conjunctival autograft, and he was able to see 20/50 like the next week. So that was a really fun case to do. So again, there are some reports of ocular surface squamous neoplasia arising next to or at the site of pterygium. They have a common pathway. Both conditions, there is damage of the p53 gene, which is called the tumor suppressor gene or guardian of the genome. So damage to this and then subsequent overexpression of the p53 gene. They are thought to be related because they have similar predisposing factors like UV exposure, potentially human papillomavirus. And in areas of high UV exposure, pterygium are more likely to have associated ocular surface squamous neoplasia. So in Australia, up to 10% at a tertiary referral center, and then about 6.6% in Montreal, which is further away from the equator. So treatment, especially if the pterygium is stable, not growing, it looks atrophic and very thin with mild vasculature. The treatment is medical. And in fact, I tried to get everybody to get on board with treating the ocular surface medically prior to any type of excision, because we know that the growth of these is related to ocular surface inflammation. So getting all of this inflammation under control prior to any type of surgery will certainly help the rate of recurrence. So cyclosporin, I try to get people on cyclosporin prior to excision, topical steroids, and preservative-free artificial tears. And we try to modulate the inflammation in the postoperative period if they do decide to remove the pterygium with steroids topically and subconjunctival dexamethasone at the end of the case as well. So indications for surgical excision, a big one would be irregular astigmatism. If the lesion's growing and has documented progression going towards the visual axis, contact lens intolerance, and then occasionally we'll have folks that are prepping for cataract surgery and they want a premium lens or a toric lens. And we kind of discuss the risk benefits alternatives that if the pterygium grows after they place a toric lens, it could make that lens less effective. So there are a few different techniques. I tend to not like to use mitomycin C for the reasons mentioned above. You can have some scleral melting and damage to the limbal stem cells and endothelium even many, many years after the pterygium resection. And some folks like to use a conjunctival autograft or an amniotic membrane graft. I think that the cosmetic result is a little bit better with a conjunctival autograft. There's less of this cicatricial kind of scarring pattern, and you're less likely to have recurrence if you use a conjunctival autograft. But occasionally I'll use an amniotic membrane graft if the pterygium is very large or if they have a double-headed pterygium. So hopefully this video will work. And I embedded it, so this wouldn't happen, but I guess there's blood in the video, so it makes us go to YouTube. is not the right one. Let's see if I can get it. Maybe if I escape. There we go. Okay, so unlike ocular surface squamous neoplasia or conditions where you're concerned about like a precancer, a cancer, we know we don't take very aggressive margins with these. I just outlined just distal to the limbus, put in a traction suture, and then remove the pterygium just distal to the limbus, making sure to get Tenon's fascia. And I like to dissect the head of the pterygium nasally going towards the limbus. If you go the other way, you run the risk of taking cornea as the pterygium kind of destroys Bowman's membrane and kind of creates these tentacles down into the cornea. So I always send it for pathology. And here the surgeon is dissecting back more Tenon's fascia. And you can see the initial incision and cut was, really small, just distal to the limbus, but these things like the Tenon's just whoosh, goes back and the conjunctiva goes back, and you usually end up with this ginormous conjunctival or scleral bed that you have to cover. So this is the technique for getting a very thin layer of conjunctiva for the conjunctival autograft. So, trying to avoid getting any Tenon's fascia. And it's better for cosmetic reasons. And also you're kind of preserving that superior quadrant. If the patient is to develop glaucoma or if they have glaucoma, you're preserving that superior conjunctiva for filtering surgeries or tubes. And then I like to anchor, like this surgeon, I like to anchor the conjunctival autograft at the limbus there. I have seen a patient in residency come in and they like totally displace their conjunctival autograft, which it takes a lot of work to get that really thin layer. And I've had a patient here just kind of pick their conjunctival autograft off their eye. This surgeon used to seal glue, which is also really helpful. It helps with hemostasis and it helps to keep that autograft in place. I still like to put a few sutures back towards the back end of the graft as well. Okay. So next up is pseudopterygium. So occasionally someone will come in with something that looks similar to a pterygium, but I do not touch these. You can get this kind of vascular conjunctivalization of the peripheral cornea with conditions where you can get thinning of the peripheral cornea, like Fuchs marginal keratitis and Terrien's marginal degeneration. And these areas are generally very, very thin. So if you remove this layer of conjunctiva, they're at a high risk for perforation, and these can really turn into a disaster really fast. A clue that it is a pseudopterygium and not a straightforward pterygium is that they tend to occur obliquely instead of at 3 and 9 o'clock going horizontally onto the cornea. So these folks, I start them on cyclosporin and preservative-free artificial tears and advise against any type of intervention or surgery. So quick note on conjunctival squamous papillomas. They're multilobulated. In young patients, they tend to be pedunculated and they can be like on a little stalk and they can have multiple of them. Older individuals are more likely to have sessile or flat papillomas. They are caused by HPV or human papillomavirus, similar to other warts or verruca on other parts of the body. They can be single or multiple, and management can be complicated by a lot of recurrences, especially in children. Sometimes you cut the stalk and then you kind of seed the rest of the ocular surface. So folks have used interferon and other drops but the most effective treatment is just simple excision with cryotherapy to the base and surrounding the base of the lesion. Folks have used oral cimetidine or Tegamet in children, and it may act as an immunomodulator and may provide a systemic method of treatment for these. So here's an example of pedunculated papilloma here on the left and a sessile flat one on the right. And these can sometimes be hard to differentiate from ocular surface squamous neoplasia, which you can see here on the left. It looks very similar to a papilloma, but it's occurring right there at the limbus, where about 95% of ocular surface squamous neoplasias arise from. This picture on the right is one of my patients that I recently removed their ocular surface squamous neoplasia. So it is a precancerous and kind of an umbrella term for precancerous and cancerous tumors of the conjunctiva and the cornea. Here's a photo of a gentleman that I met in 2019. He was in his late 80s and he worked outside on the phone lines, and he also had follicular lymphoma. So he had a little bit of immunosuppression. So you can see that raised kind of gelatinous jelly-like lesion there with those feeder vessels going up to that lesion right at the limbus there. So it's the most common non-pigmented malignancy of the conjunctiva. It's the third most common ocular tumor behind melanoma and lymphoma. They're typically localized and very slow growing. They're more common close to the equator, presumably because of the UV exposure. They can rarely involve the sinuses in the orbit, and incidence is anywhere from 0.08 to 3.4 cases per 100,000 per year. And again, common to have a mutation in the P53 gene. So in its umbrella term, so there can range anything from mild dysplasia to invasive squamous cell carcinoma. So risk factors: UVB exposure, age, fair skin, a condition called xeroderma pigmentosum, which is autosomal recessive condition. And there's a photo here of a gal who was in her 20s with many melanoma excision scars and basal cell carcinoma scars who has the xeroderma pigmentosum. Smoking is also a big risk factor, as well as immunodeficiency, HIV, systemic chemotherapy, immunosuppression for organ transplants. So one of the leading experts on ocular surface squamous neoplasia is at Bascom Palmer in Miami. And she talks a lot about in her talks how she started fellowship in the 90s and noticing a lot of these young male patients, female patients coming in with ocular surface squamous neoplasia. And she did some research. It was during the AIDS epidemic. And if the patient was under 50 years old, they were about 50% likely to have HIV. So McDonald et al. Found that about 90% of ocular surface squamous neoplasia did demonstrate some human papillomavirus infection, which is very interesting. So a lot of vaccine debates recently, but it's interesting that it's a really big public health kind of issue. I remember going through medical school when Gardasil, or the HPV vaccine, was licensed for use in the US, and a lot of resistance by some parents. But it's interesting to see, you know, the more we learn how much human carcinomas can be related to this one virus. So HPV works to promote carcinogenesis by turning off tumor suppressor genes P53 and RB. And the strains 6 and 11 account for 90% of genital warts, 16 and 18 account for 70% of cervical cancers. And in fact, virtually all cervical cancer is caused by some strain of HPV. And now we're finding that oropharyngeal cancer, about 70% is related to HPV, and anal cancer, 90%. So when I take off these lesions, I send them reflex for HPV testing, which they've done once or twice for me, but they have not been doing it recently. But it can have implications for the patient, just to know that, you know, they have HPV, and they should mention this to their primary care provider to look out for oral cancer. So slit lamp signs: there can be epithelial thickening, acanthosis, abnormal vascularization. It begins at the limbus, generally unilateral. And on exam, I take slit lamp photos. You can use fluorescein dye or rose Bengal to help highlight the extent of the lesion. I always evert the eyelids and look in the fornices and at the caruncle. And they have many different appearances, ranging from gelatinous or jelly-like to opalescent or fern-like, and it can only be, in some situations, it can only be located on the cornea. So cancer is crazy. One way to remember this, so crazy, irregular borders, less linear borders, very squiggly here on the right, and keratinization or leukoplakia is not normal. And I typically recommend biopsy in all of these cases where I see a lot of keratinization. So you can see this ocular surface squamous neoplasia on the right, in contrast to a pterygium on the left that has like the nice straight borders and that abrupt linear stop there as it approaches the visual axis. So here's an example of a gelatinous ocular surface squamous neoplasia. So very jelly-like. Here's an example of an opalescent ocular surface squamous neoplasia. These are the most likely ocular surface squamous neoplasias to be missed because they can be very subtle. They can look like pannus or band keratopathy and map dot fingerprint, but they, in contrast to band keratopathy, they're emanating from the limbus. Papillary looks like a papilloma. And then you can see this leukoplakic lesion here above an inferior gelatinous ocular surface squamous neoplasia. So a lot of academic centers use high resolution anterior segment OCT with resolution up to 1 to 2 microns. And in contrast to other conditions like lymphoma and melanoma, ocular surface squamous neoplasia is the only one with very thickened epithelium. And in fact, if it's over 120 microns, it's almost has a very high sensitivity and specificity for ocular surface squamous neoplasia. So treatment options are excisional biopsy with cryotherapy to the surgical margins, incisional biopsy, and then medical treatment. Important to note that none of these medications are on-label use for ocular surface squamous neoplasia. And excisional biopsy is generally considered to be the gold standard, just like, oncologists don't look at a lesion and just treat with chemotherapy. Tissue diagnosis is definitely the gold standard. So the pros to surgical excision would be quick resolution. It's both diagnostic and therapeutic. It's covered by insurance. The drops are pretty uniformly not covered by insurance. However, some cons would be that it can leave microscopic disease, even if you're taking these relatively large margins. There can still be microscopic disease at the lesion edge. There can be like little satellite lesions that you're obviously not treating, and these can lead to a risk of recurrence. The larger the lesion, the more likely you are to have limbal stem cell deficiency afterwards. Other risks are infection, scarring, and then you kind of run out of conjunctiva for filtering surgeries or glaucoma surgery. So for instance, this lesion, this is an ocular surface squamous neoplasia. It's outlined, but if you take 4 millimeter margins, you're run out of limbal stem cells. So surgical excision is not really a great option for this patient. So medical treatment can be used as a chemoreduction technique to make the lesion smaller prior to excision. It can be used alone to get rid of ocular surface squamous neoplasia, and it can be used if folks have positive surgical margins after excision. Some pros would be that it could treat subclinical disease and satellite lesions. There's less dependence on achieving negative surgical margins. You have reduced conjunctival scarring, and it will treat the nasolacrimal system as well. So if you have any seeding of abnormal squamous cell carcinoma in the nasolacrimal system, it'll treat this. And cons, the big con is cost, compliance, and side effects. So there was a study in 2014 which showed that the rate of recurrence was probably about equal in both groups, surgical treatment versus interferon alpha 2 beta, which is a drop that's used for this. So here I'm going to show a video of the surgical technique. Let's see. One. So first, the margins are outlined generally depending on how large the lesion is or where it's located. 2 to 4 millimeter margins will be taken, and it's a no-touch technique. So only touching normal tissue, avoiding BSS irrigation so that you're not seeding abnormal cells to other parts of the ocular surface. So again, just touching the edge, the normal margins, and using some cautery there for hemostasis. Here, they're putting on some absolute or 100% alcohol to the cornea to loosen up the epithelium so they can remove the epithelium with some margins as well to send to pathology. And here, being very careful not to invade Bowman's membrane. Sometimes you can tell, if there's a question as to whether it's a pterygium or ocular surface squamous neoplasia. You can tell because the OSSN just kind of peels off of Bowman's membrane, unlike the pterygium, which invades into Bowman's membrane. If the lesion is very adherent to sclera, then a partial sclerectomy can also be taken as well. And then the lesion's oriented on filter paper and sent for pathology. So this is a cryo probe, so it freezes the tissue. And we do a double freeze thaw cycle, kind of pulling the congentinons away from the sclera so you don't accidentally get the sclera as well. And I'll also treat the limbus with cryotherapy because that's where we think these tumors originate from. If a sclerectomy is partial thickness sclerectomy is needed to be made, some folks will apply absolute alcohol to the base of the sclerectomy as well. And I think in this video they use amniotic membrane, but again, I prefer to use a conjunctival autograft. I think there's less scarring and it's easier to tell if there is recurrence. So when I can use a conjunctival autograft, I'll do that. So there are generally 3 drops that are or were available in the US. There's mitomycin, which is used for a lot of different things, glaucoma, filtering surgery, some refractive surgery like PRK. There's 5-fluorouracil, which is used for some dermatologists for skin conditions. And then there's interferon alpha 2 beta, which I think there's 1 or 2 vials left in the US. Merck, the manufacturer, has stopped making this in favor of more targeted immunotherapies. Generally, that was the best tolerated drop was interferon alpha 2 beta with very little side effects. So mitomycin C is a potent DNA cross-linker. When I started training, it used to be the cheapest drop, and now it's actually more expensive than 5-FU. Generally, it's dosed for QID 1 week on and then 3 weeks off. These patients need to be followed super closely because they can have some delayed epithelialization and some side effects. Mean cycles to resolution, if only using mitomycin as a medical therapy without surgical intervention, is about 4 months. Lots of side effects: pain, redness, hyperemia, allergy, surface toxicity, and SBK. Some folks have corneal erosions, decreased vision. punctal stenosis. So punctal plugs are always placed, and very rarely, but a real risk would be a scleral melt, also endothelial cell loss and limbal stem cell loss as well. So papers, there aren't any randomized controlled trials on any of these interventions, kind of just some small case series. So recurrence rate can be anywhere from 0 to 17%, also used in PRK and glaucoma. So generally more side effects than the other drops and need for close follow-up. 5-FU is generally what is used now in the US. It's about $50 a cycle or per month, and it's dosed 4 times a day for 1 week on and then 3 weeks off. Same time to resolution, about 4 months or 4 cycles, and this is generally it's continued post resolution of the lesion for about 2 months in order to get any microscopic disease or satellite lesions that are no longer observable at the slit lamp. So side effects are definitely less than mitomycin C. They include pain, redness, surface toxicity, decreased vision. I have a lot of patients with eyelid edema and kind of excoriation, and I'll tell them to use some Aquaphor to help with that. And filamentary keratitis is also a side effect. And again, studies not very robust, don't contain a lot of patients, but recurrence is probably about 7 to 30%. And it's better tolerated than mitomycin C, not as well tolerated as interferon. You must cycle it, and there's definitely some ocular surface toxicity. So these photos are not mine. These are borrowed from Carol Karp, Dr. Carol Karp. But here are some examples of some of her patients that she's treated with 5-FU, only medically, no surgical intervention. And it's crazy to see how the lesion almost kind of just melts away, especially this bottom one after only 2 cycles. So the third drop, which is no longer available in the US, but our colleagues in India and Australia kind of laugh at us because it cost $1 there, whereas when it was still available here, it was costing patients about $600 a month. So it's an immunomodulated cytokine that's made by our own lymphocytes, and it's dosed 4 times a day, and no need for cycling or breaks because the side effects are so mild and rare, and it's continued for 1 to 2 months after clinical resolution. If you're worried about compliance, you can even do intralesional injections of interferon alpha 2 beta, and the average duration to clinical resolution was about 4 months. Side effects are hyperemia, follicular conjunctivitis, and some epithelial microcysts. And then with injections especially, you can get this interferon related side effects like fatigue, fevers, myalgias, so flu-like symptoms, similar to like systemic interferon that's used for things like malignant melanoma or hepatitis. So the rate of recurrence is about 6% and no longer available. Folks in Australia often use it in conjunction with retinoic acid. So here's a photo again from Dr. Carol Karp showing resolution after about 4 months of this pretty nasty looking ocular surface squamous neoplasia. So they have done a study on cryotherapy, seeing if it's necessary during surgery, and it actually decreases the recurrence rate to about 8% at 5 years, even if the folks did have positive surgical margins in relation to excision only without cryotherapy, where the recurrence rate was about 29%, 28.5%. So of course, if you have positive margins, you're more likely to have recurrence of the ocular surface squamous neoplasia. So if there are positive margins or the lesion looks to be high risk, I'll do a couple cycles of 5-FU after surgery. So even with negative margins, there can be recurrence, about 5 to 10% at 5 years. Some studies show up to about 30% of recurrence with surgery, but again, these are all using different surgical techniques. There is not like the standardized way of doing the excision. Probably recurs due to satellite lesions. So for these folks, I follow them every 4 months for the first year, every 6 months for the second year, and then yearly. And then if it's a high risk lesion, then we'll do adjuvant or post-surgery 5-FU. And I always wait to start when the eye is white and quiet and they're healed and they're no longer inflamed. So what makes a lesion more high risk? So tumors greater than 5 millimeters, extending greater than 2 millimeters onto the cornea. Also, if there's local invasion, and more pathologically aggressive tumors. So next up, I'm going to talk a little bit about primary acquired melanosis, which is not the same thing as racial melanosis, but these are always sometimes a little bit difficult to decide on a management plan for the patient. So this is an example of racial melanosis. So non-Caucasians, it was hard for me to find a really good picture, but that's generally some flat perilumbal pigment. It also can look like cobblestone-like. There are microfolds in the conjunctiva. There can be a fine spray of pigment on the peripheral cornea, and it can extend into the fornix. It's bilateral, it's symmetric, and it carries no increased risk for melanoma, so no treatment is needed. However, if you do notice that a patient has very asymmetric, what looks to be racial melanosis, this could be a sign that it is more concerning. Pigmented individuals can still develop melanoma. So PAM is different than racial melanosis. It happens in middle age in folks with light complexion. It's generally unilateral, flat, no cysts, and it does carry a risk for melanoma. The tricky part is deciding the riskiness of the lesion. You can't tell just from a slit lymph exam. It's really a pathologic or histologic risk stratification based on the atypia of the cells. So PAM without atypia basically carries a 0% risk of progression to melanoma, and same with mild atypia, but severe atypia can even be up to 32% risk of progression to melanoma in the future. These are numbers from Wills Eye in Philadelphia, so probably a little bit inflated because they're a tertiary referral center, but there is a real risk. And here's a picture on the right of a conjunctival melanoma. So, if the lesion is growing, if it looks concerning, if it's more or equal to 3 clock hours, then these lesions can be excised, generally with larger borders than the ocular surface squamous neoplasia, about 4 millimeter borders. And there are some folks that will use mitomycin C for diffuse lesions, mitomycin C 5-FU for diffuse lesions. So clinical features that make it more suspicious is a large size. So generally if it's 1 clock hour, we'll just watch it and look for signs of growth. If it's 3 clock hours, they're at higher risk. Each clock hour imparts about a 1.7 times more risk of progression to melanoma. So changes over time, if it's multifocal, if it's thicker than 1 millimeter, any type of intrinsic or extrinsic vascularity would be very concerning. Also higher level of suspicion if the patient has a history of skin or conjunctival melanoma, and then fornix location is not normal. So circling back to our patient, our 39-year-old patient here with ocular surface squamous neoplasia. So what did we do? I started interferon alpha 2 beta 4 times a day. And then I did what any self-respecting new cornea specialist would do. I referred them to the university. Kidding a little bit. It was definitely the right decision for the patient because this was a very aggressive, obviously very advanced tumor, and he really needed a multidisciplinary approach spanning many specialties. So he got in touch with the anterior segment service as well as oncology, and he was presented at tumor board. They also plugged him in with social work and with some good counselors as well. So he had an MRI which showed that the lesion was wrapping around the globe. It was displacing the lacrimal gland. The cornea service, they continued interferon. However, he was having a lot of local side effects and the lesion was continuing to progress very rapidly. He got a PET scan without any evidence of distant metastases. The interdisciplinary tumor board recommended a systemic chemotherapy called Similimab. He started this and had 2 cycles of it. However, it was discontinued due to increasing pain, and he elected to undergo surgery. So he actually underwent a surgery called exenteration which I've only seen and observed once. So they not only remove the entire globe and surrounding structures, but they remove the eyelids, fat, muscles, nerves. And the pathology came back as squamous cell carcinoma with no invasion of the eyelids, but there was a lesion suspicious for full thickness carcinoma in situ. So he is currently doing well after a few years.
So I'm Dr. Sheth. I am one of the 3 glaucoma doctors at our practice now. I think I know most people, but I trained at Georgetown for ophthalmology and then went to Baylor for glaucoma fellowship before joining this practice. Right now, some of you know I'm on maternity leave, so I apologize. I did this talk a couple months ago before taking off, but I had a bunch of cases that look like glaucoma but aren't necessarily glaucoma, which I thought was interesting. So I kind of compiled these with some of Monsi and Micah's cases as well that they've discussed in the past. So as we know, glaucoma is a leading cause of blindness in those 60 or over. It's chronic progressive optic neuropathy with characteristic visual field changes and corresponding neuroretinal rim changes. Increased IOP is not required, obviously, for the diagnosis. As we know, low tension glaucoma is a very real disease. And so visual fields respect the horizontal raphe, and that's due to the anatomic distribution of the nerve fiber layer. And so it's important that we differentiate glaucoma from other causes that the management and prognosis would differ. So first, we want to differentiate between a primary open angle and secondary because this dictates the first line therapy. And for younger patients, it's often important to check for secondary causes because this could change management, but also if there is no secondary causes, you may want to consider alternate diagnosis. But important to use visual field testing and OCT to help differentiate between glaucomatous and non-glaucomatous cases, as well as history and other factors such as color vision, asymmetry, etc. So I'm not going to really talk much about lid defects affecting visual fields, but when I was going through research about different cases, blepharospasm did come up as a cause for visual field defects that can resolve. And so this was a patient that had a history of blepharospasm, had a workup for it, but between A and B on these scans, they were treated with Botox. And so you can see resolution of the visual field defect from treatment. So that's something to consider. And then OCT can help in confirming diagnosis in certain cases and should complement our clinical exam along with visual fields. So it helps to prevent overdiagnosis. It can help evaluate the retina as well. And then it can help distinguish in certain cases that I'm going to talk about. So compressive optic neuropathy and ocular ischemic syndrome are indistinguishable from primary open angle glaucoma on OCT, but it can help with optic pits, colobomas, drusen, and ischemic optic neuropathies. So glaucoma masqueraders can mimic by painless vision loss, high IOP, visual field changes, and OCT. And this is a large list of things that I will talk about, not all of them in detail, but just to touch on. So first, congenital causes can be pits, colobomas, tilted disc syndrome, or megalopapillae. And so optic pits, I have a handful of patients. I couldn't pull up their charts for this, but this kind of gives you an example of it. And so they can be unilateral more commonly, and 15% of cases are bilateral. It's on the temporal side. And so it's thought to result from imperfect closure of the superior edge of the embryonic fissure. It correlates to an arcuate or a central defect, as it can affect the papillomacular bundle. There's normal IOP and no progression on testing. The diagnosis with OCT will show a serous macular detachment that communicates with the pit. And then the RNFL and optic nerve head parameters are typically normal. So management is not IOP lowering medications. Potential is there for laser or pars plana vitrectomy with gas for the neurosensory detachment or schisis through the macula. So colobomas are also congenital and can be isolated or associated with the anterior or retinal coloboma. So you'll have a suspicious nerve with a superior arcuate scotoma and normal IOP. It's caused by the failure of the complete closure of the proximal end of the embryonic fissure, and it's characterized by this white excavation in the disc, decentered inferiorly with a thin or absent rim, and the superior rim is normal. The OCT will show connection between the perineural space and inner layers of the temporal disc, as well as schisis extending to the macula. There's increased RNFL thickness and reduced macular thickness sometimes as well. And then topless disc syndrome, also known as superior segmental optic hypoplasia. On these, the fundus will show bilateral absence of the superior optic nerve, rim, superior peripapillary atrophy, and retinal vessels emanating from that superior optic disc. The visual field shows bilateral arcuate defects without involvement of this nasal visual field or central vision, which this field here shows well. It's non-progressive, congenital. It's usually common in females, young, and they have good vision. Risk factors are prematurity, low birth weight, and a very strong association with maternal diabetes. No treatment for this as well. And then this is just a little bit more detail. And so you can see the optic disc with missing superior rim and the peripapillary atrophy and the retinal vessels extending. And then you'll see OCT, superior OCT thinning more than inferior. And so commonly we all see optic nerve drusen. It's in 1 to 3% of the population, 75% are bilateral, but they are asymmetric. It's more common in Caucasians and it has an equal distribution between genders. It's inherited or sporadic, and it's a form of calcific degeneration in the optic nerve axons. Vision is not affected, but the field can be affected and can progress, and it can rarely lead to ischemic optic neuropathies due to compression. So they're buried or evident, and this can be confused with papilledema. OCT will show thinning of the peripapillary RNFL over time. And then calcification is picked up on B scan, which we can see in this photo, and also CT scan. It can coexist with primary open angle glaucoma. And you'll see that the disc is elevated, but the RNFL shows thinning. It's associated with retinitis pigmentosa, angioid streaks, Noonan's, Usher's, and Alagille syndrome. And so field loss may be related to direct compression of the optic nerve and its vascular supply, predisposing the nerve to disc hemorrhages and optic neuropathies. Once the disc drusen is clinically visible, there will be thinning of the nerve fiber layer. And so this can precede any visual field loss. It can enlarge with age and slowly progress over time. There's no treatment that is proven to alter case, but lowering the intraocular pressure can serve as a neuroprotective treatment. And I often do suggest this with certain patients depending on their fields. In rare cases, you can have vascular complications such as flame hemorrhages, non-arteritic ischemic optic neuropathy, or peripapillary subretinal neovascularization. So I have a few cases of patients, just how they presented differently. So a 64-year-old male was transferred from Kaiser. He was diagnosed with POAG prior to coming to me and treated with latanoprost. His Tmax was 16 and 10, and he had an average corneal thickness. So these were his fields. And so the left eye has a little bit of some scattered changes, but you can see in the right eye, there's a inferior nasal step extending. And so these were his optic nerve photos. And you see there's not significant cupping. It's hard to see any elevation of the nerve, but on autofluorescence on that right nerve, you can see the superior drusen. And so on the OCT, you can also see that superior thinning more on the right nerve than the left. And so just to go back, that corresponds to that inferior defect on the visual field. And then this was an 80-year-old Caucasian female, also transferred with a history of open-angle glaucoma on latanoprost, and has a history of optic nerve drusen. She had a family history in her mom and maternal grandmother on drops, and had upper limit of normal pressures of 21 and 19 with average packs. So these were her fields. And she has she has a nasal defect in both eyes and a little bit of an inferior defect in that left nerve. But you can kind of see on this progression in the graph that it's been fairly stable over several years. And these were her optic nerve photos and autofluorescence, which shows significant drusen. And you can see there's a lot more drusen on her photos compared to the last patient, but less defects. And these were her OCTs over time. And so they're actually very stable, but do show some thinning of the RNFL more on the left eye than the right eye. And then the last case of optic nerve drusen is a 62-year-old Caucasian male who was on timolol. He was a high-risk glaucoma suspect with a 28-year history of a nasal defect. He has an APD of the left nerve or left eye and Tmax of 23. On timolol, his pressures are 10 and 12 with a thick pachymetry. And these are his fields. So you can see he has a much denser defect on the left, and the right eye is fairly early superior nasal step, which explains his afferent pupillary defect. And these were his photos and optic autofluorescence showing his optic nerve drusen. And this was his OCT, so you can see he has a significant thinning of the RNFL in both eyes, more on the left than the right. But it has been stable for several years as well. So the next thing that can present as glaucoma or optic neuropathy, so ischemic versus non-ischemic, compressive, inflammatory or infectious, toxic, nutritional, traumatic, or hereditary dominant optic atrophy, but I'm not going to discuss all of these in detail. But AION is an acute unilateral painful optic neuropathy in patients older than 50 with permanent vision loss. Ischemia occurs at the optic nerve head due to structural crowding with impaired perfusion and leads to optic disc edema. It accounts for about 5 to 10% of ischemic optic neuropathies, and it results from inflammation and subsequent thrombosis of the short posterior ciliary arteries, resulting in the optic nerve head infarctions. Patients generally have a small disc and cup with pallor. They have normal IOPs. They manifest with decreased vision, usually worse than 2200, an altitudinal defect, APD, and a chalky white pallor, pallorous nerve with edema. It can be indistinguishable from non-arteritic ischemic optic neuropathy. And so we want to do a thorough workup to make sure we're not missing this. And so amaurosis can present with this. And then you want to rule out GCA history, so headaches, temporal tenderness, jaw claudication. We want to do the labs for GCA and a temporal artery biopsy depending on suspicion. And if this is the case, treatment is high-dose steroids. And then non-arteritic ischemic optic neuropathy is usually the vast majority of the optic neuropathies we see. It's more common, obviously, than arteritic, but it's idiopathic and can be associated with sleep apnea, certain medications like Viagra, optic nerve drusen. It's more commonly in Caucasians, and again, equal distribution between males and females. Pathophysiology is controversial, and no one mechanism is proven, but presumed circulatory insufficiency is thought. And most have that classic disc at risk appearance. So these will also present with decreased vision, abnormal color, an APD, swollen optic nerve, flame hemorrhages, and visual field defects. Usually they have a hyperemic nerve, not pallor early. And so they'll have painless unilateral vision loss that expands over hours to days. There's no treatment for this, and it can worsen over 2 weeks and stabilize. But there is a 3 to 8% chance of recurrence in the same eye, and a fellow eye involvement of 15 to 24% over 5 years. And so this case was a patient I saw actually as an emergency, but had previously presented to Dr. Kanoff. She was a 67-year-old Caucasian female with a gray temporal quadrant for 5 days, denied any pain. She has a complex history of breast cancer, history of idiopathic intracranial hypertension, optic nerve drusen of the left eye. And so she was found to have optic nerve swelling and denied any GCA symptoms. Labs were done, were normal. She had an MRI just due to her presentation, and this was normal of the orbits and had shown a normal variant of her right carotid indenting the optic nerve. She previously had a negative sleep apnea test with cardiology and normal blood pressure readings. So this was her presentation in May. It's a little hard to tell from the photos, but there's elevation, segmental elevation, and hyperemia of the right nerve. And then she presented actually in July to see me, and the left nerve is involved. And the right nerve, the elevation and blurring the margins has resolved. So this was her autofluorescence just to show the disc drusen that she had on the left. And so when she came in May of 2020 and June of 2020, she had OCTs done that initially looked normal in the right from the hyperemia and the elevation. But subsequently, as that elevation resolved, she had RNFL thinning that you can see has stayed stable over the last year in the right eye. And then in the left eye, you can see the second to last photo that there was an increase in her RNFL, and that's due to the optic nerve swelling. But as it resolved several months later, you can see that there's resultant thinning. And then this is her visual field. So when she presented in May or June of 2020, there was that superior defect involving fixation in her right eye, and her left eye was fairly normal. And then as she presented this year, you can see that there's involvement of her left superior field as well. So she is an unfortunate case of bilateral involvement and fellow eye involvement, but she had repeated labs and sleep study done that was normal. She eventually had been started on blood pressure drops medication, so the evening dose was stopped with cardiology, and bromonidine was added for possible neuroprotection of the nerve. So compressive lesions can also affect visual fields and OCTs. And so tumors of the nerve orbit intracranial areas, vascular lesions, orbital disease, such as thyroid disease or orbital apex. These can have proptosis and increased IOP from increased epivenous scleral pressure. And OCTs for these patients usually have all parameters decreased. So this can be confused with glaucoma when the visual field loss is slow. You want to raise suspicion when there's unilateral disease, worsening visual field in the setting of controlled IOP. Cupping will be disproportionate to the visual field loss. Vision loss, you'll have color vision loss and pallor, which is not common in glaucoma until very late in the disease. And then traumatic optic neuropathy, you expect to have a history of trauma, but not always, asymmetric cupping or pallor, and variable visual field defects. So this patient was a patient referred to me very early on when I joined the practice, and she was a 47-year-old Hispanic female, so relatively young, but referred for worsening fields. She had presented 4 months prior to an outside ophthalmologist with 1 month of blurred vision, had hypertension, no APD, vision was 20/25 and 20/40, and Tmax was 19 and 20, so upper limit of normal, and on prostaglandin was 14. Her gonioscopy is open, denied any history of trauma. Her optic nerve shows some cupping and some temporal pallor, but no notching or severely cupped nerve. And this was her presenting visual field to the outside ophthalmologist. And so there's generalized depression and a significant, what stood out to me on this field was the temporal nature of how dense her defect was. And then this was her repeat field where she had pretty much blacked out vision in her left, blacked out visual field on the left and a central island on the right. And this was over the course of 3 months, 2 to 3 months. So obviously significant progression very quick in a young patient. Did not sit right with me, and she had a stat MRI done, and this was her OCT that shows diffuse thinning as well. But her MRI did show a large pituitary mass. She was sent to the university and had treatment. She didn't follow up with me, so I don't have follow-up information on her. But again, very classic case of something that just didn't smell right. And then this was another patient in our practice who was 56, so also still on the younger side, Caucasian female, referred for glaucoma evaluation. She, on presentation to me, was complaining of decreased contrast and interestingly stated that she saw pink instead of red and had been worsening over 2 years. And she also noticed that maybe her peripheral vision was just not as sharp as it used to be. Her vision was decreased at 20/60 and 20/40. She had normal pressures, but I did check color vision given her complaints of contrast changes, and she had abnormal color vision, which had never been checked before, but again, not common in a female. So this was her visual field on workup that day, and you can see the classic bitemporal hemianopsia. Her optic nerves, again, a little hard to tell, but they do show some temporal pallor, not significant cupping that would explain this, but again, does look like what a glaucoma suspect eval should look. But this was her OCT, and you can see significant RNFL thinning of the right more than the left nerve, but it has stayed stable. And I don't have her imaging, but she was diagnosed with a pituitary tumor. But after treatment, her follow-up visual fields actually have significantly improved and are stable, which is really reassuring. So other neurologic considerations, patients that have previous optic nerve swelling, so MS patients, papilledema patients will have resultant optic atrophy, and that can change the structure and appearance of the nerve. If you want to ask for a history of these, non-glaucomatous neuropathies affect the papillomacular bundle, so often gives that temporal optic nerve pallor, presents as a paracentral or secocentral visual field defect early in the course, although some low tension glaucoma cases can present with central vision loss too. History is important. So previous strokes, surgeries, which I'll show you some cases of surgical visual field defects that present like glaucoma. You want to check for sudden or quickly progressing vision loss, asymmetric changes, lack of color, double temporal graying or amaurosis symptoms, and orbital aches or pains. Disc pallor is a hallmark for a non-glaucomatous condition. Proptosis, ptosis, facial asymmetry. Loss of central vision without a loss of peripheral vision is common. Central scotomas or fields that respect the vertical midline are common in these cases as well. The optic nerves can be symmetric in appearance in non-glaucomatous cases, but one visual field is very different than the other. And then color desaturation. So this is just a kind of a schematic of the different areas on the visual pathway that can, different lesions that can cause the corresponding visual field defects. I'm not going to go into a lot of detail about these necessarily, but this is a patient of mine that is a glaucoma, ocular hypertension patient that had a stroke of that left, the occipital lobe, which you can see as number 9 here, macular sparing, but it's been very stable. And so I had another patient who is a 67-year-old that actually was referred for cataract and glaucoma evaluation very recently. I didn't get this history of his seizures with removal of scar tissue until I asked him further about history after seeing his visual fields, but he did have scar tissue removed from the right temporal lobe, which you'll see why it's important to know that, and he had normal IOPs. So this was his visual field on presentation, and so he has the superior quadrantenopsia that corresponds to that brain surgery that he had. Again, it's the first field, so obviously I would want to follow this to make sure, but this was his corresponding OCT and optic nerves. So there is a little bit more cupping on the left nerve than the right, but overall a nice healthy neuroretinal rim and equal. And then I have a patient who is a Caucasian male referred for glaucoma. He has elevated pressures with the average pachymetry, but interestingly, he has a history of cerebral palsy with right-sided weakness since childhood or since birth. And so he has this visual field defect as well. It's hard to know if this is related to his cerebral palsy diagnosis. I don't think I have the multiple visual fields attached to this, but they have been stable over time. But we are treating his ocular hypertension, and you can see his OCTs have been stable, but he does have RNFL thinning and his nerves are not that worrisome for cupping, but again, with that field defect and the RNFL and IOP elevation, he is being treated. And then this patient is mine as well, 68-year-old Caucasian female with a history of MS. She has a strong family history and her dad of significant glaucoma, but normal Tmax of 17, but with pretty thin pachymetries. She does have an APD in the right eye, and she was previously diagnosed with normal tension and was on timolol. So these are her OCTs, and you can see that she has significant RNFL thinning, which could be related to her previous bouts of optic neuritis with, from her MS diagnosis. But they have been stable since 2016 or 2015, since I've been seeing her. And this was her fundus photo, and she has a history of retinal laser. And then if you look at her optic nerves, you can see that there is a significant amount of cupping as well, with the vessels emanating from the edge of the rim there, more on the right than the left. Her fields actually, given her OCT appearance and optic nerve appearance, actually are not worrisome at all, but given her family history and these appearances, I don't think there's any harm in keeping her on treatment, and she's happy to do that as well. So next, retinal cases can present with confusing pictures as well. So Dr. Tilton did talk a lot more about vascular occlusions, and so I'm not going to go into, I don't have a lot of detail about that as much as he did, but retinal artery occlusions can appear as an arcuate-like defect due to having the same vascular supply. On exam, you'll see emboli or sclerotic vessels. The optic nerve can have pallor but not cupping. And vein occlusion, so a central vein occlusion may have collateral vessels, but branched retinal vein occlusions can have residual retinal hemorrhages. So a symptomatic artery occlusion requires immediate attention and transfer to a stroke center. It's due to obstruction of the blood flow to emboli, vasculitis, or spasms. Lack of oxygen leads to the severe vision loss in the ischemic retina, and risk factors are usually cardiovascular, so hypertension, obesity, diabetes, coagulopathies can also be associated with this in cardiovascular disease. It's ischemia of the inner retina, and so it becomes first edematous and then atrophies. You want to rule out GCA in older patients and vasculitis and hypercoagulable states in younger patients. And chronic signs are pale nerves, thin retinal tissue, attenuated vessels, and RPE modeling and decreased vision. So this patient was a patient referred for a second opinion for a right visual field defect that was found incidentally. She had no family history of glaucoma. hypertension and hyperlipidemia, and then normal pressures and fairly normal vision. Her nerves were concerning for cupping. And so this was her visual field, and you can see this dense inferior defect respecting that midline and horizontal axes on the right. But interestingly, her OCT shows this borderline thinning of the RNFL on the right nerve and normal left, but you can see on the ganglion cell analysis significant thinning in this superior temporal quadrant. So interestingly, she had a OCT done, and through the macula, it's nice and looks healthy, but if you scroll superiorly, you can see that loss of that inner retinal tissue. And so it was thought that she had a previous artery occlusion in that area, which was causing this the visual field defect that was not diagnosed previously or noticed by the patient previously. And then branch retinal vein occlusions can occur when the thrombus occurs at the AV crossing from emboli or atherosclerosis, and it causes compression and occlusion of the retinal vein. Again, similar risk factors, and exams can have cotton wool spots, retinal hemorrhages, edema, subretinal fluid, and neovascularization. So this is a patient I share with Dr. Kanoff, but she is a 77-year-old Hispanic female that was monitored by him for branch retinal vein occlusion and CME, but was referred by her primary ophthalmologist for worsening fields. She had been on 4 drops with still borderline pressures of 18 and 19. And so this was a fundus, fundus photos that you can see the significant diabetic retinopathy she has. And then on this left nerve, you can see the pallor inferiorly, and then the sclerotic vessels emanating from it. And so this is over time, a couple of years apart, but the nerve itself looks fairly stable. And so this was her OCT from the outside provider that shows inferior RNFL thinning on the left, and then her ganglion cell analysis in both eyes shows significant thinning. This was our RNFL for her, and this was her OCT through the macula with some edema. But this was her visual field on presentation to me. So she has a dense superior arcuate defect involving fixation on that left, and the right eye has an early arcuate defect. From her outside provider, you can see that over time there has been dense, her defect has increased over time and become more dense and involved fixation early on, but has progressed some. And so she actually did undergo a tube shunt surgery because after talking to Dr. Kanoff, it wasn't thought that her exam for her vein occlusion and CME was causing the progression. And so even though her nerve looks stable, given the field defects and being on 4 drops with borderline pressures, it's thought that just controlling that pressure will hopefully stabilize her field defect. And it's too early to tell, but that's the hope. And her pressures have been good. So, and so then I think this would be the last one on the retina vein occlusions. This was a 70-year-old. A Caucasian female presented in 2019 for a second opinion for glaucoma. She had been started on drops 2 years prior and had multiple drops tried, but for unknown amount of time. And so unclear if she was stopped due to intolerances or just ineffectiveness of them. Her Tmax was 22 and 23 with slightly thin packs. And she had an MRI due to asymmetric cupping and notching that showed a small old infarct versus a prominent perivascular space. And so in 2019, her visual fields and OCT progressed in the right eye, and multiple drops were added and tried, but she had intolerances. In May, she presented with amaurosis symptoms and was found to have a partially ischemic BRVO. She had a carotid and echo and labs that were all normal. And she interestingly has had continued alternating disc hemorrhages So this was her fundus photo, and you can see the segmental area inferior temporally in the right eye of these hemorrhages in the sclerotic vessel. And she actually has a disc hemorrhage in the left nerve at the same time. And then over time, she's flipped and had disc hemorrhages in the right eye as well. Just another look at these hemorrhages that have been flip-flopping. These are her OCTs, so inferior thinning of the right RNFL, which correlates to that vein occlusion as well, and a normal RNFL in the left eye. This was her field this year. So she has this superior nasal defect in the right eye and a full field in the left. That has been stable. However, with these alternating disc hemorrhages and multiple drug intolerances, we're trying to decide how closely to monitor versus surgical treatment, as she hasn't tolerated anything other than Vyzulta, which is cost prohibitive. But just this kind of shows it's hard to differentiate what's causing what. So is it the retina causing this defect or glaucoma on top of it masking it? So just want to have close observation. And then this was an interesting patient retinitis pigmentosa, I'll talk about the patient in a second, is a genetically heterogeneous group of inherited disorders that have progressive dysfunction of the rod photoreceptors with subsequent degeneration of the RPE and the cones. They present with night blindness and progressive visual field loss, and there's no known risk factors other than genetic predisposition. So this is an interesting patient that was initially seen on the East Coast and diagnosed with ANA and placed on prostaglandin for borderline pressures by her ophthalmologist. And then she's been traveling back and forth. So I inherited her, and these are her fields. So significant superior arcuate defects and nasal defects involving fixation. She has had some progression since I started seeing her. But these are her photos, and you can see she has significant cupping, but what's interesting is that she has RPE changes in this arcuate fashion, and autofluorescence actually shows it really well. That corresponds to her visual field loss, and over time that it has progressed. And so the visual field changes that she has correlate to the RPE modeling and atrophy, and not necessarily her glaucoma diagnosis with controlled IOPs. So again, we're just monitoring her and continuing on drops for this. And then the last retina thought I was gonna mention is that, so there's a Schwartz-Matsui syndrome that involves ocular hypertension in the setting of a chronic RD caused by anterior dialysis at the aura. It's due to chronic release of the photoreceptor outer segments. And so you'll see anterior pigmented cell, increased IOP with fluctuations in an RD on exam. So this patient was a 75-year-old female that moved from Pennsylvania, was establishing care as a glaucoma suspect. She had normal pressures with slightly thin pachymetries and no family history and mild cup to disc asymmetry. She had a visual field done for baseline testing, and you can see she had a nasal defect in that left nerve, or sorry, nasal defect on that left field. And then these were her nerves, so not any significant cupping, but her fundus photo shows this well-demarcated RD with laser that correlates to that nasal defect. And so just something else that can cause visual field defects and not necessarily glaucoma. And her OCTs were nice and normal. So glaucoma masqueraders can mimic by painless vision loss, elevated IOP, visual field changes, and OCT changes. There's a huge list of things that can mimic, obviously, so history is important in exam findings. So this is just a little table that kind of shows acuity is normal until latent glaucoma versus non-glaucomatous causes of loss. Age is sorry, that says optic neuropathy, but any non-glaucomatous causes. Age is usually older in glaucoma patients and can be younger in non-glaucomatous causes. There's more pallor in the non-glaucomatous cases, and usually the inferior and superior rim is affected versus temporal rim in non-glaucomatous. And then disc hemorrhages can appear in glaucoma, but can also appear in optic neuropathies, for example. So RNFL loss on imaging is common in superior and inferior rims in the glaucoma, but usually temporal loss in the non-glaucomatous cases. And then arcuate defects are usually superior, inferior, or nasal in glaucoma versus paracentral in the non-glaucomatous cases. APD depending on symmetry. And then IOP can be normal, increased, or low in glaucoma, but usually normal in the non-glaucomatous cases. So be on the lookout for uncommon field loss patterns, assess risk factors or lack thereof, be aware of anomalous optic discs, and use OCT and visual field as supplement and not a standalone diagnostic tool.
And then a question about would SLT offer neuroprotection in optic nerve head drusen?
I don't know that it's necessarily neuroprotection that there's controversial studies about brimonidine or alpha-GAN having neuroprotection, but I don't think there's any harm in lowering IOP in those patients. And so I often talk to patients with optic nerve drusen that have visual field defects and let them know that it can be progressive, but because of the drusen, you don't appreciate the cupping as well. And so starting treatment is not a bad option, and SLT is a good option as well, lowering the pressure if they have borderline risk factors for that. And I leave it up to the patient unless there's something significant on their field or OCT that I think warrants treatment early.
And then for the patient with inferior arcuate retinal pigment modeling and arcuate defects, was that a type of retinitis pigmentosa?
Yeah, so she actually, I think, sees Elijah as well. So I don't know if he wants to chime in, but she was diagnosed with atypical RP. Let me find her here. I don't know if Elijah's still here.
Yeah, I can't remember exactly. I'm pretty sure that we've gotten genetic testing that confirmed her diagnosis and her particular mutation, but I don't recall if it's a specific patient or not. By the way, genetic testing has just been fantastic for retinitis pigmentosa, and many of these cases like this one, or others where patients don't even know that they have any problems until we look at their retinas and discover pigmentary changes, peripheral changes, and being able to order genetic tests and find out the specific mutation just makes my job so much easier. And obviously, if you're worried about glaucoma, this one obviously corresponds to the pigmentary change is quite obvious, but in other cases it may not be quite as obvious, and it gives us reassurance that we're made the right diagnosis.
That's a great point. There was one other question for Dr. Werner, if she could share her QR code.
I can pull them up if it helps.
Yeah, and I was going to throw them all up at the end too, after I have that PDF with all of them. So I'll show them one more time, but I can do that as well.
There's Amy's.
At the end.
Do you want me to pull it up? I can do it too.
Yeah, I can. I was going to throw them all up at the end too,
Okay.
and just kind of scroll through them. So, but I'll probably just do it at the end.
This is Amy's. I don't know if my screen's still sharing, but that's hers.
Your screen is sharing, but it's just your PowerPoint. But that's
weird.
That's fine. I think I'll throw them all up at the end. That way, everyone has one last chance to kind of get those QR codes. Well, I'm going to go ahead and get started if there's not any other questions. And so again, I'm Carl Noble. I'm one of the new retina people starting off here. I know I haven't met any of you probably, besides maybe some referral letters or sharing some patients, but excited to meet you all and hopefully in the near future. I'm from Ohio originally, moved around a lot with when I was in the Navy, but did my training in Washington, D.C., and then for residency, and then my fellowship in Cincinnati, Ohio. I am a Browns fan, so if anyone is watching the game, I would really appreciate not sharing the score until I have a chance to catch up. And I will assume that all jokes are hilarious. Since I can't see any of your faces, I will just assume that there's much laughter going on in the background. So today I'm going to be talking about scleral fixated intraocular lenses. This is something I think is very interesting for us who are doing this procedure. We'll talk about some of the various ways to help these patients out in this situation and kind of indications. I have no financial disclosures related to this topic. So we're going to talk about the indications for this type of surgery. We'll go through different surgical techniques, talk about the complications that can occur with this surgery, and then go through some resources as well. So, at the end of the day, this is not an ideal situation to be in. We don't want to have to do scleral fixated IOLs or anterior chamber IOLs, and it all comes down to capsular support. So in an ideal situation, we're putting an intraocular lens inside the bag or the capsule, and a secondary choice is going to be anterior to the capsule or in the sulcus. But when there's no capsular support, we have to come up with alternative solutions, and there's some kind of older ways we've been doing this and more creative ways that have come out in the last 10, 20 years to solve this problem. There's also reasons why, in addition to the capsule being violated itself, you can also have zonular weakness. This can be from a complicated cataract surgery, various ocular disorders like Marfan syndrome or homocystinuria, and also can be iatrogenic from either intraocular injections, a scleral buckle, or previous vitrectomies can lead to inadequate zonular support. So this is an example of a crystalline lens that has gone into the soup, and we also have, looks like some interesting retinal pathology here, looks like a retinal detachment as well. So this will be a very fun case for whoever who's trying to repair this. This is an example of a intraocular one-piece lens that is dropped as well. And then this is an example of a patient with Marfan's, and you can see the significant zonular laxity here in the lens, which is now superior and temporal location as opposed to being central. So what do we do for these patients? There's a lot of different options, and I've had patients who are so myopic that leaving them aphakic is actually not a bad option. And so discussing with them about, if they're still relatively plano with no lens at all, then leaving them with no intervention besides removing the dislocated IOL or crystalline lens is a potential option for them. Contact lenses can be good options for patients. A lot of our older patients have difficulty putting contact lenses in, so that's not a perfect option for everybody. An anterior chamber lens is still a great option, more of something we did a lot more in the past, but a lot of people are still reaching for anterior chamber lenses, and if sized correctly, this can be a fantastic option for patients. And there's also iris fixated lenses, and I'll show you some examples of those. So to the left, you can see this is an intraocular lens placed in the anterior chamber. It has these kind of foots here, or feet rather, that are kind of in here on both sides to kind of wedge it into place. This on the right here is a iris fixated lens, and you can see here it's kind of threaded through the iris stroma there to fixate it into place. There's several downsides, and this is not the focus of my talk here, but there are some downsides to using an anterior chamber lens. If sized incorrectly and having mobility of the lens can lead to corneal breakdown as well as iris chafing, which can lead to bleeding, high pressure, and ultimately corneal endothelial loss, requiring corneal transplant and sometimes removal of the lens. With the iris fixated lenses, can have some similar problems, but a lot of it has to do with iris chafing and iritis, and less commonly in the anterior chamber lens with endothelial loss, but this can also happen as well. You can just imagine there's less space or less space between the cornea and the lens when it's anterior to the iris. So we're going to focus on scleral fixated lenses for this discussion. When these patients come into the office, I think it's super important to just have a very long, detailed discussion about expectations. This is not a standard cataract surgery. Patients aren't going to be 20/20 on post-op day one, and oftentimes these patients will need some refractive updates after surgery, as this surgery is still not a refractive surgery. It often needs some glasses afterwards. There's also no reliable toric or multifocal option. Some people are doing toric lenses, and I've seen some multifocal surgeries that people have done. I find that they are very unreliable and not something I typically would recommend for patients. So these are all things that you have to really hone in with the patient before surgery. So ways to fixate a lens inside of the eye without a capsule: you can use glue, a scleral tunnel, suture. People in the past were typically using polypropylene or Prolene sutures. These worked very well for about 10 years and then tended to fracture and break, causing the lens to then dislocate much later down the road. This is fine, I guess, if you're at the tail end of your career, but I'm just starting, so I'll have more than 10 years of patient care, so I prefer them not to break until well after I retire. That was, again, another hilarious joke. But yes, the Prolene, most people aren't using that anymore, and we've switched to Gore-Tex, which is essentially really expensive dental floss that's sterile, never been used on the teeth. And this was actually used by cardiothoracic surgeons initially, and has had awesome results for longevity and strength. We have not been using this in ophthalmology as long, but based on the cardiothoracic literature, this should, fingers crossed, have a much longer longevity than the Prolene sutures. And this is what most people are using now when they're sewing a lens to the sclera. So I'm going to start with the first case here. I hope you guys are okay with surgical videos. That's mostly what this talk is. So this was a case I did about a year and a half ago. It's a younger patient, 40, who was assaulted and presented with an open globe injury. So initially repaired her open globe. You'll see some sutures along the superior aspect of her limbus, and she then subsequently, after the globe repair, needed a vitrectomy, removal of her dislocated crystalline lens. And you will also see too, I think this is why this is a nice case to display, there's no iris here. And so it really helps visualize how we put the lens in. So this is an Invista lens, or an MX60. It's a Bausch & Lomb acrylic lens, which means it can be folded. So it's a gummy lens. And there's some advantages to doing this, because with a foldable lens, we can make a smaller, clearer corneal incision, not much bigger than we would for a typical cataract surgery, which has advantages. I will say with this type of lens, the biggest disadvantage would be that the eyelets that you'll see that we've threaded the suture through can rip. And if you tighten your Gore-Tex suture too much, that can cause rippage at the eyelet. And also too, this is a non-rounded optic. So iris chafing can be problematic in these cases. However, in this case, the patient has no iris, and so chafing is not as much of a concern. So we start off, this is not how fast I operate. This was sped up to keep everyone not sleeping. But we make a peritomy 180 degrees apart, 2 separate peritomies. We then cauterize the bed of the sclera. We then put an infusion in. We measure 2 millimeters back and make 4 sclerotomies with a 25 gauge trocar. My technician decided to turn on the infusion there for me. And we then make a clear corneal incision. And you'll see here, this is and I have a picture that you'll see as well, but this is the MX60 lens. There's these eyelets that you thread the Gore-Tex through. This white string here is the Gore-Tex suture. It then goes over and under this, so through the eyelet and then back around and on top of the actual haptic. And again, I have a picture that kind of helps display that a little bit better. Oh, I thought I did, but not in this version apparently. But there's basically it goes over the eyelet, and then you actually see it pretty well in the video as well. So then we thread the Gore-Tex sutures through both ends, both of these sclerotomies, and then pull this to take out the slack. We fold the lens and insert it into, this is a unicameral eye, but we insert it into the eye behind the iris. Then there's a 3-throw to somewhat secure one side. Then do a handshake technique here where we pass off the Gore-Tex suture on the other side. Then again, another handoff procedure here. And you can see that the suture got behind the haptic here. So I kind of had to do a little gymnastics to get it back around. And now you can see that, again, the suture is going on both sides. So this is going from on top through the eyelet and then underneath this little piece of acrylic here, and then back over top of this haptic here. So both sides of the suture are on top is how you keep it oriented. And then we do a 3-throw on this side and kind of position it here. I thought this case was really nice because with no iris, you can really tell that it's centered, which is kind of nice. And so we suture that down, and then we would close the sclerotomies and then be done with the case. So this patient did really well. She got to 20/40 without correction with this lens, where she was uninsured, and so kind of had to go through a lot of gymnastics to get this case done at all. But we're trying to get her an iris prosthesis, but was not able to get that in for her during my tenure in Cincinnati, but hopefully in the near future we can get that approved for her. But right now she's managing the glare with dark sunglasses. So again, this is a great type of lens and technique to use. The biggest concerns I have with this type of procedure is the fracture, which usually occurs here at the eyelet if you over tighten the suture. And then this optic is a non-rounded optic. So with the iris contracting and dilating, it can cause iris chafing and iris loss. Let me see here. Yeah, so the size of, I'll go through all the sizes of the lenses, but all these are 6 millimeter optics, except for one of them, which is the CZ70. It's kind of nice because I can't remember the optic size all the time, but luckily they tell you in the lens description here. So an MX60, it's a 6 millimeter optic. And that's about the only way I can remember sometimes. One of the optics we're going to use is a Honkin 7 millimeter optic, and that's super nice for certain cases. So this is an Acryos Technique, an AO60 lens. So this is another Bausch & Lomb product that, again, none of these IOLs are designed for this technique. They're all designed to be put in the bag. There's actually no lens that's designed specifically for, besides an ACIOL, that's designed or approved to be put outside of the bag. We do these kind of all off-label techniques. And so this is an Acryos lens, again, a Bausch & Lomb product, 6mm optic, but it has these 4 foot plates that you can suture to. Again, similar thing, we're doing peritomies, cauterizing, infusion, setting our horizontal at 3 and 9 to make sure we have good track of where we're putting our sutures here, making 4 sclerotomies, roughly 2.5 back from the limbus. In this case, we're making a scleral tunnel because this is a little bit of a larger lens to put in. This is a dislocated intraocular lens here that fell back. This patient had prior vitrectomies for retinal detachment repair, and this lens dislocated several years after their cataract surgery. You'll note here there's a large Sommerings ring, which can make things complicated if you do what I did for this case, which is, you'll see it here in a sec, kind of have to open up the sclerotomy, the scleral tunnel rather, a little bit. But oh, there goes that Sommerings ring. So we had to do a break out the phacophragmatome, which is essentially a honking device there that, much like a cataract surgery, kind of breaks up that Sommerings ring. So I apologize that the camera's a little bit up and to the left there, but I wanted you to see the lens, which is why we did that for this case. But you can see here, this is the Acryos lens. It's got these foot plates. So much like the last case, we fed the Gore-Tex suture through the superior sclerotomy, because we're sitting at the head of the bed here, goes out through that scleral tunnel, and then we're going to feed it through these foot plates. So the suture goes through the first one, over the top, underneath, and then from the bottom up the second foot plate. We then do a handoff technique through the sclerotomy and then through that inferior scleral pass there. We'll then repeat the same process for the other side. If I can get the handshake here, sometimes it takes a little time. And got it. Okay, so now we got the handshake done, and then we're going to make sure our sutures are aligned correctly and do the same process on this side, and then pass that off. And this is a little diagram I made here showing you how that works. So through the first sclerotomy, out the scleral tunnel there, and then through that first foot plate there, second, and then back through that second sclerotomy. So you can see that when the lens goes in, it actually flips and turns in because the top here will end up being on the bottom when the IOL is actually inside of the eye. So then we're going to insert this. We ended up having to fold that. Those foot plates kind of can get stuck going through the scleral tunnel. So inject a little viscoelastic there, OVD, and then able to get it in. Then we suture the scleral tunnel with some nylon sutures, and then close the sclerotomy after we tie down the Gore-Tex sutures here. Again, this isn't a 3-1-1-1 pass. And again, this is not how fast I operate. I wish. Unfortunately, I'm a little slower than this. And then we kind of bury those knots, trim the edges, and then close the peritomies there. So similar technique to doing the to doing the MX60 as far as making peritomies and then suturing the Gore-Tex to the scleral wall after putting the IOL in, but just a little bit of a variance of the similar technique here. So this is a CZ70BD lens, which is different than the other two, those Bausch & Lomb products. One is the two Bausch & Lomb products, like I talked about, they're not rounded optics. And so when the lens is in the eye with the iris contraction dilation, it can cause chafing at the iris. So the CZ70 lens has a rounded optic edge, which is nice. It does decrease the risk of iris chafing. The other thing here too is, like I mentioned before, this 7 here is because the optic is 7 millimeters. It's a big honking lens going in the eye as far as the optic goes, which is really nice. It gives you a lot more wiggle room as far as centration and decreases the risk of you having, if you're a little bit off the center, it's much more forgiving, I guess, is the best way to say that. The downside is with a PMMA lens, this is essentially like putting plexiglass in the eye. It does not fold. And so you have to make a large scleral tunnel to get this, or a large wound to get this inside of the eye. Some people do a clear corneal incision. I prefer using a scleral tunnel to decrease the risk of stigmatism from that wound. So again, kind of a similar reason for surgery, that this is a dislocated intraocular lens that occurred fairly quickly after surgery. This patient had a history of trauma after cataract surgery that resulted in this lens dislocation. This is a pretty, I usually do a much larger scleral tunnel for this. We tried a shorter scleral tunnel. This is really just a limbal wound that we created. But typically I like to go a little further back, but this case, we had a little more of an anterior approach. We inject viscoelastic, trying to inject inside of the same bubble, and you can create this you can create one single bubble inside the anterior chamber, which protects the endothelium. We do a vitrectomy here and get the intraocular lens into the anterior chamber and secure it and just anterior to the iris. This patient, history of vitrectomy and prior laser there, you can see. And so we're then making our sclerotomies. This is roughly 3.5 millimeters back, and not making a peritomy in this case, or doing a conjunctival cut down, and kind of a different way to approach this, where you can do a pass off underneath these two sclerotomies, which is kind of a unique way to do it. For this case, it was a nice approach. But here's the Gore-Tex suture. We put it through the sclerotomy there and get it just behind the iris. And you'll see for both sides. And then we'll thread it through the other sclerotomy. And then we'll externalize both of these Gore-Tex sutures through that scleral tunnel, which we're opening right now. So removing that one-piece lens, externalizing these Gore-Tex sutures, and you make a knot around the optic here, you'll see, and this is called a cow hitch technique, where you kind of create this loop, taking note not to twist these or get these sides confused, because that can really mess up the centration. And then you feed this, you'll see this, it has this little eyelet or notch on the haptic there, and you kind of thread that cow hitch over that optic, that haptic eyelet, and then that really nicely secures the lens in place. with 4-point fixation. The downside of doing that type of knot technique is you cannot rotate it. So we'll show you how you get around that issue there. So we get the lens inside of the eye through that scleral tunnel, and then behind the iris for the other optic. You then tighten the most counterclockwise Gore-Tex suture. And you'll see here, we're passing, instead of using a peritomy here, we're actually passing the suture through those two sclerotomy passes. And then we're gonna tighten the suture, again, using a 3-1-1-1 technique over that counterclockwise sclerotomy. Since you can't rotate the knot, this suture knot has to be right over your sclerotomy, or it can be very difficult to bury it. So here's the first one. We'll tie that, and then we're gonna make a kind of a baseball stitch style suture. For those who do extra cap cataract surgery, this is kind of a nice suturing technique to close these larger wounds, which I really like. And then we're gonna do the same thing on the other side and pass off that suture again on this side, and a similar technique on that counterclockwise side, and then we'll tighten again in 3-1-1. And you can see here, this is a really large optic, super forgiving, and this patient did really well. So tying over that sclerotomy site, important to keep that in mind when you're doing these, and then we'll tighten that down. And then bury that suture on both sides. So this is a really nice technique, like I said, and I do love this lens when it's inside of the eye, but a lot of people don't like this technique because of the large scleral tunnel and and here we're doing a vitrectomy just to remove some of the blood and the viscoelastic that I felt in the back of the eye. And so a lot of people don't like making that corneal or scleral tunnel because it can be a little bit difficult to suture. And so this is some post-op kind of shots of that that incision, and then really pretty quiet eye compared. And this is showing you what these sutures look like after surgery underneath the conjunctiva. So one last video here. This is a little different technique than the other ones I've shown. We're not using Gore-Tex for this. This is a fixating the haptic to the wall through a scleral tunnel technique. This is a Yamane lens, which is a CT Lucia lens made by Zeiss. This is a 6mm optic as well. I like this technique and this lens a lot. It has a rounded optic, which is makes it a much more favorable to limit the risk of iris chafing. So in this case, we again put our trocars in for infusion, as well as 2 other trocars for instrumentation. This is our infusion here. We make a incision, inject OVD into, or viscoelastic into the anterior chamber. This is a patient who is, again, you can see a recurring theme here, multiple prior surgeries, and then a dislocated intraocular lens. She's had a prior vitrectomy with extensive endolaser here. And we do our vitrectomy, we get the lens into the anterior chamber. This case, the patient also had capsular instability noted at the time of surgery for cataract surgery, and so there's a capsular tension ring inside this IOL complex that had to be removed as well. So get into the anterior chamber and make our clear corneal incision. Again, this technique is nice because it's a foldable lens, and so we can make a small 275 or 3 millimeter lens to get the new lens inside of the eye, which is much less induced astigmatism for that type of procedure. We're removing the intraocular lens, and then here's that capsular tension ring that we're taking out as well. And then we kind of burp out some of that capsular bag that was residual there. Re-inject OVD to protect, or viscoelastic rather, to protect our endothelium. We're going to mark our horizontals at 3 and 9. So this technique with the Yamane, to create our scleral passes or tunnels, we use this, or the technique I like to do is to use a thin-walled 30-gauge needle. These are made out of Japan. It's called a TSK 30-gauge needle. Kind of a cool thing you'll see. A regular 30 gauge, the diameter of the lumen is, because of the not being thin-walled, is too small to actually fit the haptic of these lenses. And so this type of needle creates a super small incision, but also you can feed the haptic through these thin-walled needles. So you kind of bevel this, bevel up rather, and then inject the needle, insert the needle rather, 2 millimeters posterior to the limbus, and then angle it back here and put it underneath the iris. And so then you can inject your Zeiss lens here and catch it through that opening or lumen of this 30 gauge needle. You then inject this further, and then you externalize this haptic. And this is a, like I said, a lens made by Zeiss, and this lens is bulletproof. Done some really cool studies in animal models where they've looked at trying to pull these haptics out, and it's very, very durable and sturdy lens. But what you do is you take low temp cautery and you create a little bit of a bulb at the end of this proline here, and that creates it fixates then inside of the scleral tunnel there. So then you repeat the same process here on the other side. I will say the second pass is a little trickier. I think this is where most people get hung up with this technique, is this second pass. It's just a little ergonomically a little trickier, but you can see there, I edited out my first fail there, but I did miss it on the first pass. But on the second pass, we get it here and kind of tuck it through that lumen again, secures really nicely, really forgiving once you kind of get it secured in there. Externalize, dry it, low temp cautery, create that little bulb on the end, and just kind of seat it down and move the conj over that little piece of haptic sticking out, which then really nicely lays down. We then create a peripheral iridotomy there with our cutter, and then remove the blood, and then take out our trocars, and then we're done with the case. You can see here, this is a really nicely centered lens, no tilt, and this patient did very well with this technique. So I hope you enjoyed those cases. Those were all surgeries that done over the last year, and really enjoy doing these cases. I find them challenging, but have some really nice results, and hopefully patients will have long-term improvement of their vision with these types of techniques. Some complications that can arise from these procedures, some of them are a little more unique to doing sutured techniques, would be suture erosion. And so that this is an example of suture erosion for a case with Gore-Tex suture, and this can lead to infection. This is now an externalized or exposed to the outside world piece of material that is then connected to the inside of the eye, which is concerning for risk of endophthalmitis. We have to take these back to the operating room typically, and then close the conjunctiva over the suture. Sometimes we even do a scleral patch graft over the Gore-Tex suture as well. Usually suture erosion can occur from patient rubbing their eye. This can also be from a loose suture that has more mobility, and sometimes we have to tack those back with some various techniques as well. We talked about suture fracture. This occurs more commonly with the Prolene sutures when they're suturing with the Prolene suture to the scleral wall. And that's why most of us have switched over using Gore-Tex. Iris chafing and uveitis glaucoma hyphema syndrome, or UGH, is sometimes can occur with these types of cases, especially with excessive amounts of lens tilt. This is an example of a Yamane technique that shows an example of that. So you can see here, this is all iris atrophy over here. And then with retroillumination, you can see that your intraocular lens is here and kind of pushing up against the iris there. And this is an anterior chamber OCT showing, actually, no, this is a ultrasound showing the amount of tilt. And this is actually directly pushing up against your iris. So in this situation, you know, the intraocular lens had to be removed to alleviate the patient's issues. And then, like any cataract surgery, you can have issues with vitreous hemorrhage, hypotony, corneal edema. You can have cystoid macular edema, infection, retinal attachments, etc. I find that we get a lot more issues with hypotony and hemorrhage than you would in the classic cataract surgery, which is fairly rare. But these cases, you have to make a lot more incisions into the eye. So hypotony is fairly common. Oftentimes, I'll inject sterile air into the eye at the end of the case to make sure we don't have issues with hypotony. And one thing I thought I put on here, but it looks like I don't, is you can get pupillary block with these. And so you always want to put in a peripheral iridotomy. I think the last case was the only one that actually my edit showed that, but all the cases we put in a PI for these patients to limit the risk of pupillary block. So in summary, you know, hopefully we all get to meet each other here in the near future, but I'm really a pleasure to present these cases for you. I hope you enjoyed. You know, at the end of the day, our goal is to put a lens in the bag. And if that doesn't work, we have options, but none of them are perfect. And all of them are fairly difficult from a technical aspect surgically. But luckily, we do have options for patients. And I think that a lot of these can have really phenomenal visual results and longevity for our patients. So this is my contact information. If you have any questions about retina and have a difficult case or want to send me an OCT or for a patient over, we're always happy to help. And hopefully, like I said, we get to meet in the near future. And hopefully the Browns are winning. So we'll see. These are my resources.